Ladies and gentlemen, it gives me the greatest pleasure to welcome you today to the World Asthma Day academic program organized by the Sri Lanka College of Pulmonologists. The Airway Assembly of the Sri Lanka College of Pulmonologists has organized 3 separate activities to commemorate World Asthma Day. First off, an academic program closing gaps in asthma care. Secondly, an art competition. And finally, a series of public awareness programs carried out by various media outlets. We have an interesting lineup of several lectures organized for you today, and I kindly request our audience to please keep their mobile phones on silent mode at all times. To begin today's activities, let me cordially invite Dr. Ravini Karunatilaka, President of the Sri Lanka College of Pulmonologists, to deliver the welcome address.
Good morning, ladies and gentlemen, my dear teachers, colleagues, and friends. It is my pleasure and privilege to welcome you to today's academic program organized by the Airway Assembly of the Sri Lanka College of Pulmonologists to commemorate the World Asthma Day 2022. Each year, on the first Tuesday in the month of May, the world commemorates the Asthma Day, and this year the theme is Closing Gaps in Asthma Care. Asthma burden across the globe is around 5 to 10%. And in 2013, a screening questionnaire-based study on wheezing gave us a local statistics around 23.9%. But it is now understood that a diagnosis of asthma by symptoms alone can lead to an overdiagnosis by 30%. I feel the biggest gap we are facing in asthma care is that we are unaware of the actual number of asthmatics amongst us at present. This shows us the need for a robust study to establish the prevalence of asthma in Sri Lanka so that we may structure our policy decisions around scientific knowledge. Understanding the asthma phenotypes and comorbidities that lead to poor control should be a part of the assessment of each individual asthma patient. Another point to remember is that it is important that we actively engage our asthma patient in managing his or her disease. I am pleased to announce that in addition to our academic program, we have initiated an art competition and numerous other educational activities to improve awareness and to understand the perspectives of the community on asthma. It is with gratitude that I acknowledge all those who have worked hard to make this possible, and a special thank you to Dr. Tushara Galabada, Chair of the Airway Assembly of the Sri Lanka College of Pulmonologists, and to all other resource persons presenting today. I hope that today's program will give you insight into a complex topic of asthma, and most importantly, help change your approach to an asthma patient. I conclude with a quote from the European Respiratory Society Asthma Guideline on Diagnosis, which says, "Asthma is like love. Everybody says that they know what it is, but nobody has the same definition." Thank you.
Ladies and gentlemen, we will now be moving on to announce the winners of the art competition. This was organized by the Airway Assembly of the Sri Lanka College of Pulmonologists, and despite short notice, we are pleased to announce that we have had a large number of entries which were judged by a panel comprising of a respiratory physician and an art instructor from the Colombo division of the Department of Education. However, unfortunately, due to the prevailing conditions, only the names of the winners will be announced today, and the awards will be couriered off to the winners. So first off, in first place of the grade 1 to 2 category, we have Minulya Senal of Mairapad Junior School, Narammala. Second place goes to Sayuni Vijayatunga, Maliyadeva Girls School, Kurunegala. And the third place goes to Manudha Vitanage of Uva Mahavidyalaya Badulla and Metumdi Ritara Galahena of North Melbourne Primary School. From the grade 3 to 5 category, the first place goes to Yashodhara Sirivardhana of St. Joseph's Girls School, Kegol. Second place is secured by Netini Seara Kalpage of Mahamaya Balika Vidyalaya Kandy. Third place goes to Imadi Ratnavira of Ferguson High School, Ratnapura. From the grade 6 to 8 category, the first place is secured by Kavini Ratnavira, Ferguson High School, Ratnapura. Second place, Nulaya Senumti Chandasena of Ferguson High School, Ratnapura. And finally, the third place is secured by Disas Vijay Sundar Ranasinghe of Anand Vidyalaya, Colombo 10. And from the grade 9 to 11 category, the first place is secured by Netumli Rasmita Mulleriava from Sirimau Balika Mahavidyalaya, Colombo 7. Second place is secured by M.A.H. Kalhara of Mayurapad Central College, Narammala. And finally, the third place goes to Tisansa Kurukul Surya of Girls High School, Kandy. And from the grade 12 to 13 category, the first place goes to Dulakshi Nimesha Veerapokuna of Sri Sarananda Adarsha Mahavidyalaya, Manellambua. And second place goes to Semini Ashodhya Ratnayaka of Ratnavali Balika Vidyalaya, Gampaha. And finally, third place goes to Tilotma Tatsarani Veersari of Vishaka Vidyalaya, Colombo. We extend our heartiest congratulations to all the winners. And now, ladies and gentlemen, we will be moving on to the first symposium of today. And to chair this event, I would cordially like to invite Dr. Afla Sadikin, Consultant Respiratory Physician of the Colombo South Teaching Hospital.
Good morning, everybody. It's a privilege and an honor for me to be as the chairperson for this important event that is our collaborating with our College of Pulmonologists. We are celebrating the World Asthma Day, and today we are just going along with the world theme, that is the closing gaps in asthma care. So to start the sessions today, we are going to start with a very interesting lecture that is on diagnosis of asthma and its clinical behavior. I want to introduce Dr. Niranjan Disanayaka, who is a consultant respiratory physician from Teaching Hospital Ratnapura, and he's not a stranger to our community. So over to you, Niranjan, to talk about diagnosis of asthma and its clinical behavior.
Thank you very much, Afla. Let me have a few minutes to share my screen. Thank you very much, Afla, again, and I would like to extend my thanks to the College of Pulmonologists, especially to Shara, the chairperson of the assemblies of Airway, as well as Ravini, for giving me this opportunity to speak to you today of an interesting topic. And I think it is aptly named this time, this year's World Asthma Day is aptly named as Closing the Gaps. And we as clinicians, I think, will agree that there are many, many gaps, specifically in the local setup, that we can close, facilitating improving care of asthma patients. And unfortunately, about 250 million people suffer of asthma, and 500,000 succumb to this completely curable disease unnecessarily in the world. And Sri Lanka, being one of the highest prevalent countries out of the world population, I think have immensely suffered due to asthma, and it continues to suffer because of asthma. And it is time that the College of Pulmonologists try to close this gap, and I think this is the right step forward. I think the best way to highlight this gap is to discuss about this girl. Actually, this is not that person's child's picture, which I think that if I use it, it is unethical. This is a picture downloaded from the internet. And but the story is a true story. When I was working in a peripheral hospital in Badulla, which I saw this girl, a 13-year-old girl who came with episodes of past history. When I look at the past history, there were multiple episodes of cough and wheeze. And every month, almost every month, every 2 to 3 weeks, the girl has gone to the GP or the local doctor, and unfortunately, the patient has been given oral salbutamol and some antibiotics, probably some steroids, and then sent home. And unfortunately, she has hospitalized with two severe attacks, needing hospitalization in the base hospital that was near this village in Mayangana. And unfortunately, even during the admission and after discharge, this girl has not been diagnosed as asthma and has not initiated a proper treatment. And there were many, glaring. It was, Asthma was saying that I'm asthma loudly in this girl. There was a family history. Mother and child was also sibling were also wheezing. Obviously, there was a poor socioeconomic state. The father was working uh, in a factory nearby, burning bricks, and they were living in a two-bedroom house with its crowded and used firewood to cook. And then the father was smoking inside the house. And this poor girl was bedwetting at 13 years, and he has missed school a lot. She's not doing well in school, and she actually avoids eye contact even with me while talking. And obviously, she's depressed. And this is basically the story of asthma in most of parts in our country, in Sri Lanka at the moment. And unfortunately, we think about sophisticated interventions in pulmonology, but actually, this is the true story and the true picture in majority of the cases. And it is time that we get our act together, I think. Right. While asthma, actually, not in Sri Lanka only, in the worldwide population also, asthma is underdiagnosed. Unfortunately, out of 10 out of 2 people, 1 in 5 who has asthma is not diagnosed properly and not initiated on the proper treatment, increase in the suffering. And unfortunately, this undiagnosed asthma population is mostly in the underprivileged group of people in our society with a low education level, female sex, occupational exposure, and elderly, and with a low household income. And I think it is not different in Sri Lanka, and my colleagues will agree on that. And at the same time, specific groups of people are overdiagnosed, specifically the obese people are overdiagnosed of having asthma. And these patients who complain of shortness of breath are prescribed an inhaler. This happens actually in the urban and the suburban areas where drugs are freely available and inhalers are freely available. We have seen that happen many times. And usually these can be overdiagnosed, or the concurrent other problems are neglected, just solely treating asthma per se. And we have seen heart failure coexisting with asthma, or heart failure per se is being undertreated or not treated properly with the diagnosis of asthma. And it is not basically abnormal in all of the literature, world of literature, it is there, right? So sometimes we overdiagnose patients with this pulmonary hypertension, maybe due to valvular heart disease or primary pulmonary hypertension, with shortness of breath. We treat the patients with inhalers, send the patient home, no for proper follow-up, and then the outcomes of the patients will be not that bright. Bronchiectasis, we have seen in many instances being diagnosed and managed as asthma, just not listen to the lungs to get the cause creps, and not to take a history, proper history to see whether there is a productive cough in the patient, so that the diagnosis and the management would differ in these patients, and these patients are prescribed steroid-only inhalers. In the elderly, Archiamas are just emaciated ones are just getting DPI, dry body inhalers, and subsequently getting oral candidiasis and hoarse voice without any benefit whatsoever for their control of the disease. And tuberculosis, again, being Sri Lanka being a medium burden country, we have seen recent onset wheezing and cough only being treated as asthma in certain instances. And finally, at the end of as the patient is not improving, finally get the x-ray, and then they'll see that the patient is having tuberculosis, and by then the lung is completely damaged and irreversibly damaged, and the patient has given the disease to a lot of people. And interstitial lung disease as well, a new entity to the clinical setup made in the preliminary healthcare system, and it is also being neglected and managed as asthma in most of the instances, not looking for the the fine crepes and the obvious clinical signs that might show that the patient is having asthma. So there are a lot of gaps there, certainly. And the unfortunate thing is sometimes malignancy per se can be missed. Not looking a history of hemoptysis, a history of smoking, looking for clubbing, just treating the patient as asthma for the simple cough will have dire consequences of the patient. A grade 1 or grade 2 cancer can be propagated into grade 4, 5 irreversible cancers. And it is unfortunate to see this in the setup. Why do we have this problem? Mainly, one is the lack of knowledge, obviously, and the lack of awareness in the primary healthcare system, as well as in many OPD medical professionals in our country, as well as unawareness of that problem in the population. But one specific sign that is unique to asthma is that asthma, basically, there's no standard definition for asthma. There is a definition, there are definitions in guidelines, but these definitions are, I would agree that I think my colleagues will agree, are vague, and they are vague and they are not very specific. Now, for example, if you say diabetes, we have a cutoff value of fasting blood sugar, HbA1c, for rheumatoid arthritis, there are designated criteria to say whether it is rheumatoid arthritis or not. But in asthma, unfortunately, we are still grappling with the clinical definition that can cover up asthma, because asthma is basically a syndrome. It is not the disease, and it has many etiologies, and it is heterogeneous. And sometimes, probably within the next 2 or 3 years, we probably might have to separate the asthma syndrome into several clinical entities, which are more manageable and more definable depending on the endotypes. But still then, unfortunately, we have to deal with this definition of asthma, which is non-specific. And for the primary care physician and the non-expert, it might cause problems in defining and diagnosing asthma. Hence, my talk today would be to summarize within about 10 slides what we should do or what we can do to improve the diagnostic specificity of asthma in the Sri Lankan context, given the basis of the international context as well. When we look at the definition, as I discussed previously, it's a heterogeneous disease. It doesn't behave in a simple way. It is very heterogeneous. Some people can come with a simple cough, and some people can have multitudes of symptoms associated with asthma. Some people will have recurrent exacerbations. Some people have about 16 to 20% will have no symptoms for about 2 to 3 years after a single exacerbation, and in between they will be completely normal. Hence, you can understand the diversity of the presentation as well as the disease. And the disease origin, there are multitudes of disease origin theories. The Th2 predominant theory gaining ground with the hygiene theory, and there are non-eosinophilic asthmas. There are certain phenotypes that are there that behave differently from other types of people. For example, catamenial asthma, which is common in older females, which has exacerbations previous to the asthma, will not respond to corticosteroid, but will respond to montelukast and leukotrienes better. So there are large, diverse groups of people amongst us with various clinical characteristics. And even though it is said that there is chronic inflammation and there is asthma phenotype where there is no inflammation, but there is airway dysfunction, mainly because of the hypersensitivity to the neuropeptides in the bronchial epithelium. Hence, inflammation per se, which was a hallmark of asthma, in certain group of people, we might not find inflammation at all. Hence, when we do a BAL, we get a post-cellular bronchoalveolar lavage. And respiratory symptoms, wheeze, shortness of breath, chest tightness, and cough. And if you ask anyone from the road, you might have this one or more combination of these symptoms would have been present in many of these people. And sometimes it is very difficult because these symptoms are non-specific, from a simple viral infection with the post-inflammatory bronchospasm to viral bronchitis to eosinophilic bronchitis. There are many other differential diagnoses for these. Hence, the diagnosis might not be apparent in most of the people. And there will be a variable expiratory airflow limitation, which we can demonstrate in asthma. And even there, it might not be specific for this for asthma. But to make matters simple, I think if we take asthma as a chronic disease, I think that is the best way to analyze asthma. And what better way to look at the temporal pattern of asthma. And this is a typical temporal pattern of asthmatic patient, where it will be a chronic disease. If you ask the patient, about majority of them, 70 to 80% will say that there have been episodes of wheezing, cough, symptoms of asthma during the last probably 2 to 3 years. And if it is a very short duration, we have to be a little bit careful to see whether we are dealing with another differential diagnosis. So these exacerbation of symptoms can be very severe, sometimes even life-threatening, needing ICU care, hospital admission. And then suddenly after treatment, he will go into a complete remission of symptoms without any symptoms. That doesn't say that the inflammatory process or the process of asthma has gone completely. And then after that, suddenly he might get a low-grade symptom, which might be there again. So this is the difficulty in asthma. But this variability of clinical presentation is a hallmark of asthma, unlike other respiratory disease. For example, interstitial lung disease will have a progressive shortness of breath with a dry cough. COPD will have progressive shortness of breath with episodic wheezing and exacerbation, but he will never be normal at all, unlike in asthma. So there are certain things that we might have to look at in the history to see whether the patient is behaving as an asthmatic patient. Their hallmark will be a chronic disease which has exacerbations and remissions, complete remissions in between, where you will have different degrees of exacerbations depending on the patient's exposures. And the four main symptoms of asthma, as we know, are cough, wheezing, chest tightness, and shortness of breath, mainly because of the narrowing of the airways, which is the hallmark of asthma, where it will increase the resistance with increased period of breathing, where the patient will have increased shortness of breath. And at the same time, this irritation due to the inflammation and the secretions of mucus and stimulation of the nerve fibers will cause cough. Sometimes it is intractable cough and with associated wheezing, and there will be chest tightness. And chest tightness will be different from chest pain. Chest tightness is the heaviness of the chest, and some people complain of back pain as well. And sometimes these patients go to the cardiologist and comes with a normal echocardiogram. And hence, these are the four hallmarks of asthma symptoms. And usually they tend to occur more than one. That means if you have a single symptom like cough only, then you have to be very skeptical whether it is asthma only, even though there is a condition called cough variant asthma. But basically, if the symptoms are single, we have to always think whether we are dealing with asthma per se. But if you have multitudes of symptoms coming together out of these four, then the probability of this being asthma is high. And why these exacerbations occur, and then if you ask the patient, even when you have an exacerbation, there will be certain triggers of this patient, from simple allergens where the patient has been sensitized, the commonest in Sri Lanka being the dust mite, and there are fungi, the molds, as well as the cobwebs, which are common in the peripheral rural setup. And these are the commonest allergens that we can see. So that when the patient is getting exposed to the sensitized allergen, they can get these exacerbations. And exercise, again, especially in small children as well as in certain adolescent groups, we can see a significant amount of exercise-induced bronchoconstriction, which is the now name for exercise-induced asthma. And we see a lot of people with that, and reducing their exercise capacity and the functional ability of these children and adolescents. Stress, we have seen many their children who should, especially before the scholarship exams, especially before the A levels, who have been under control, who didn't have asthma symptoms previously, who had asthma symptoms and completely remission, have been coming with exacerbations or increased symptoms such as chest tightness, which is associated with anxiety. Hence, stress is another important thing that we have to think about, and other than the irritant. So when we look at a person's history, this variable history of exacerbations, remissions, partial remissions, so the last symptoms, with one of more of these symptoms, probably more than one of these symptoms coming in and going, and then again coming in and going, and where the triggers are identified, I think we are dealing with more towards asthma than any other disease that we can have this type of clinical picture. And it is important to consider this in our differential diagnosis of asthma. So that is basically the history part. And this is what I was discussing previously, right? So this wheezing, shortness of this from the GINA guidelines, from the clinical history, more than one type of respiratory system. Symptoms occur variably over time. Worse at night, there's a significant diurnal variation in these patients because of the tone of the smooth muscle varies, as well as the temperature drops, and hence there will be a change in the patient's symptoms. In waking and night, there will be increased symptoms, and some people get up at around 2:30 to 3 in the AM in the night with cough and wheezing, unfortunately, and it is usually triggered with exercise, and usually, especially in small children, less than 7 years, preschool, there is a tendency to increase these symptoms with viral infection. And I think my colleagues will agree that after the COVID pandemic, we see a lot of patients who have been previously asthmatic or had wheezing, who had been on remission for a long time, now coming with the features of allergic rhinitis and bronchial asthma. Hence, there is a separate pathway, and we have identified and we have pathologically defined how the viral particle stimulates the innate lymphocytes, and through the interleukin 25 and 33, how it comes in, creates a eosinophilic type of inflammation in the bronchi, and probably might be the reason that now we see a little bit of more exacerbations of asthma after the COVID epidemic, and fortunately during the COVID epidemic, because I think the studies have shown budesonide specifically has a protective effect against COVID. Maybe because of that, we saw a little bit of low amount of exacerbation because of COVID per se, but post-COVID, we see a lot of viral, post-COVID asthma exacerbations, so asthma symptoms that are coming new than previously, right? Okay, so these are all our subjective symptoms, and now we have to go into the objective symptoms. And by definition, asthma is a variable airway disease. That means it can worsen or it can improve. And one of the things that we can look for where the improvement is by doing the reversibility test. And one of the most important reversibility tests is the spirometry that we can do, and we can see the normal. You can see the normal graph in a normal person and an asthmatic graph in the red line. This is for the postgraduate. And after ideally inhaling 4 puffs of salbutamol, that is 400 micrograms in an adult, after about 15 to 20 minutes, if this airway is completely reversible, you can see a significant improvement of the lung functions. And specifically, when you do a flow volume loop, usually you get this coving, the red side, you can see a nice coving here, and you after because that's a hallmark of obstructive airway disease. Even in COPD you can get that, but unlike in COPD, after nebulizing or after giving a short-term bronchodilator, it can completely reverse back to the normal. So this is the hallmark of asthma, where reversibility or the variability is you can deteriorate as well, but reversibility is the problem. Sorry, there's a call. And according to the GINA guidelines, the most important thing is, other than the symptoms, we have to confirm variable expression. They had to confirm the variability of the airway narrowing. And specifically, if a patient comes to you at the first instance with FE1 of less than 70, then you have to look at the FE1 to FEC ratio, and if it is less than 0.7, then there is evidence of obstructive airway disease. So at a time when FE1 of a person is less than normal, we have to look at the FE1 to FEC ratio to see whether at the initial setup, whether it is less than 70, so that we can identify whether this patient is having obstructive airway disease. Right. And later, we can conduct a reversibility study. Usually, one way of doing the reversibility study is, as I suggested, to do it's the easiest one from a spacer. We can use the 100 microgram salbutamol inhaler, 4 puffs, and then about 20 minutes later, 15 to 20 minutes later, we can look at the reversibility. And usually in adults, there will be a more than 12% reversibility and a more than 200 milliliter. And this is very important, more than 12% with a more than 200 milliliter elevation of the FEV1, and in children the characteristics are different. But we know that even from the spirometer to spirometer, from person to person, from day to day, there will be a significant variability, sometimes even going up to about 10 to 12%. And so if you have a 15% increase and more than 400 milliliter increase in FEV1, that is almost conclusive of variable airway disease. But if it is even to more than 12 and more than 200 in the correct clinical setup, we can consider that it as a reversible airway disease. So if we have the clinical criteria or the presentation criteria of asthma, as well as this variability that has been proven, more likely we are dealing with asthmatic patient. There are other ways of checking for asthma. One is that airway hyperresponsiveness. Now, earlier we checked the airway when the patient had a narrowed airway because of the trigger. Already the airway is narrowed, but when the patient doesn't have significant airway narrowing, if we can trigger this, then it will be very important to see whether this airway is hyperresponsive. One important thing that we use is methacholine. Methacholine is a very important substance that we can use, but not in Sri Lanka. We can't. I have not heard about it being used. So after a specific dose of methacholine, we expect a decrease in FEV1 of more than 20%. Then that says that this patient is having hyperresponsive hyperresponsiveness. So, but it is rather sensitive but not specific, because the change can occur in various diseases. Hence, it is not sensitive, so specific, but it can be sensitive in a patient who probably has asthma with the clinical symptoms, when the reversibility is not there. If you do a methacholine, if you see a 20% drop, that person might have asthma. In the correct context, we can think about that as well. And one other important thing that we can trigger airway hyperresponsiveness is by doing the ecapnic voluntary hyperventilation, where specifically in patients who are having exercise-induced bronchoconstriction, we can look at this by after the patient does a specified amount of exercise, breathing specified amount of air with a concentration of air. Then if you look at a FEV1 less than 10% drop, then we can think about whether this patient is having airway hyperresponsiveness. This says that there is airway hyperresponsiveness only, which is sometimes it is a hallmark of asthma. But we have to remember that there are other conditions that can cause airway hyperresponsiveness. So we have to break it in the clinical context as well before coming into a conclusion. Right. So positive exercise challenges more than 10%, and post-bronchial challenges more than 20%. It is standard methacholine, and we can some people use mannitol, some people use histamine, and that is the way that you have to go. How about exhaled nitric oxide? This is has been there for some time, and there was a lot of important debate about it. But the most important thing is exhaled nitric oxide is basically a marker. It's a marker of type 2 inflammation, eosinophilic inflammation. Hence, in eosinophilic asthma, yes, it definitely has a space. So if a patient is having a history suggestive of asthma, and if we want to know whether this patient will be corticosteroid sensitive, nitric oxide more than 50 parts per billion will give us an indication that this patient might be responsive to corticosteroid therapy. Again, eosinophilic bronchitis, eosinophilic pneumonias, and other eosinophilic inflammations can falsely trigger this value up. Hence, again, the specificity is low. But for some treatment decisions in difficult cases, we can use the FeNO, and sometimes we can use it to monitor the response to treatment as well in certain instances. But it is basically, it is again a tool that we have to look at certain groups of asthma, specifically the Th2 predominant group of asthma, where eosinophilic inflammation is there, but not in all asthma types, right? So to use it basically not to diagnose asthma at certain instances, yes, but to control these patients' treatment initiation and continuation. Right. In summary, what we have to see is that this is a basic summary. So there are two main characteristics of that we are thinking about. One is the clinical spectrum of the disease, which is a chronic inflammatory disorder, a chronic disease with variable symptoms, which can come and go. And Sometimes it's completely reversible, and then with the objective cause of showing that there is variable airway obstruction in this patient. So if these two tallies together, and certain family histories and certain exposure histories tallies, then it is one of the important things that we have to look for. So patients with respiratory symptoms, the most important thing is to take what a detailed history and examination for asthma, and and then usually the lungs will be normal, or you will have expiratory bronchi. The Krebs, fine Krebs, pleural rubs, bronchial breathing are very unlikely findings. And then the perforation should be performed by peak expiratory flow rate or a reversibility test, and then we can diagnose the patient with asthma. But if doesn't fit, even the history and the examination doesn't fit asthma, we have to think about the alternative diagnosis before going in and treating the patient with asthma. Now, in a country where we have a lot of where facilities to investigate and treat conditions, yes, this might be the correct pathway. But unfortunately, in a low or middle income country with the current situation in Sri Lanka as well, we might be challenged to diagnose asthma according to these guidelines. Hence, now specifically in our countries, there is about 34 to 50% of undiagnosed asthma cases, unfortunately, in the community, as well as there is about 30% overdiagnosed asthma as well. And that is one of the major gaps that we have to think about closing. And in this setup, what the GINA suggests is that we can look at the peak expiratory flow rate for the variability. Usually we look at the peak expiratory flow rate about 10% variability in 2 weeks time. What we do is we take the daily maximum, daily minimum, and then we take the daily mean to the two added together and the mean, and then we divide the difference between the maximum and the minimum with the mean, and usually it is about 9%. The normal when is the adult, and in children it's about 12.47. So hence we take a cutoff of more than 10% variability in peak expiratory flow rate as a variable airway obstruction in adults. We can use this peak expiratory flow rate, and unfortunately it is not freely available again in even in the government health sector, in the chest clinics. Hence, our diagnosis, according to this criteria, might also be hindered, even though the GINA has suggested and WHO has named peak expiratory flow rates are essential equipment. Hence, sometimes we might have to go in low resource settings to document the symptoms, and then do a peak expiratory flow rate, and then probably go for a therapeutic trial with the inhaled corticosteroid and as required LABA, and then give a oral corticosteroid and see the response to treatment to see whether these patients are responding. And most of us, I think, are currently doing this after diagnosing asthma. Now, at the end, I would like to stress again that even though asthma seems a rather simple disease with wheezing, cough, and chest tightness, it has many challenges to the physician, and you will learn during the day about the challenges that it poses. Severe asthma, what is the roles of biologics, and what are the new things in asthma that we have to deal about in the current literature. So there are a lot of new developments in asthma that is coming in the world. There are new drugs that are coming out, but unfortunately at the local level, at the ground level, at the peripheral level, we are dealing simply with diagnostic difficulties, and we are dealing with management difficulties, and patients unfortunately are not getting the optimum care they should have. Unfortunately, that is the true story. And because of that, these children, these adolescents, and these workers, and these mothers and fathers are suffering. And hence, we have a huge gap to fill. And I hope that we as a college, as well as a medical fraternity, can rise up to the challenge and do the needful. Thank you very much.
Thank you very much, Niranjan, for that comprehensive and very interesting talk on the diagnosis and the clinical behavior of asthma. So just to wind up the first session, the first talk, let me ask one question, since we don't have questions from the podium. I thought of asking you that. Now, you emphasize the importance of history in case of diagnosis of asthma. And also you mentioned that about therapeutic trial. So what I feel is about this clinical emergency, since it's a a disease where it's an intermittent presentation in certain situations where you get the patient in an emergency set up as an exacerbation or maybe the first presentation. How important it is in those cases to continue and monitor therapeutic trial if in a clinical emergency for the diagnosis of asthma.
Yeah, I think we see that daily, isn't it? Now, after a patient comes with a heart attack and admitted to even a base hospital or a district hospital, we see a correct plan given to the patient of following them up, arranging a 2D echo, possibly a PCI, and there is escalation of treatment, there is continuation of treatment. We advise the patient to control the hypertension, cholesterol, and come back to the clinic in about 2 weeks. But unfortunately, most of these people with asthma exacerbations who come to even provincial general hospitals and above base hospitals, unfortunately, they are not given a proper plan of management. And that is, as you said, is one of the reasons that this is probably the best instance that we can catch these patients, because now these patients comes to us with exacerbation. That means his asthma has not been under control, and he's prone to get the next exacerbation, and it might be life-threatening. But unfortunately, we just because of probably the heavy load that we have in the wards, in the general medical setup, these patients are sent home without a correct plan of management, and sometimes the diagnosis and the management is different. I think one of the most important things that we should emphasize, as probably there are some medical registrars here as well, is that asthma is a life-threatening condition like ischemic heart disease, like heart attacks. Hence, always we have to have a correct plan of management. And as for your question, yes, this is a very, very important time to initiate the therapeutic trial of these patients, because we will not lose anything else by initiating it, and we can arrange for a 2-week follow-up for this patient. That is what we usually do in our setup. And then we investigate this patient further for probable asthma mimics and whether this is asthma or not. And then we can go further from there for investigations and management. So in our setup, in Sri Lankan setup, probably we might have to increase the catching or increase involving these patients more after getting admitted, and we should have a proper discharge plan, and probably we might have to have a guideline on discharging asthma patients to the primary sector to improve the outcomes.
Thank you very much, Niranjan. So let me ask my co-chair, Dr. Tushar Galabala, to introduce our next speaker.
Thank you, Afla. There is slight change of the program. Dr. Sumed Samankant will join us shortly. So the next lecture will be on uncontrolled asthma clinician's approach. It will be done by Dr. Amita Fernando, consultant respiratory physician in NHSL. Dr. Amita Fernando is not a stranger for us, very active member of our assembly as well, and giving immense support throughout. So Dr. Amita Fernando will talk on uncontrolled asthma clinician's approach. Over to you, sir.
And thank you for inviting me from the assembly, Airway assembly. Good morning to you all. This is the outline of my. I won't make it. Okay, right. So this is the outline of my talk, and I'll move on to my talk proper. GINA defines asthma control as minimal or no daytime symptoms, no limitation of activity, no nocturnal symptoms, minimal to no need of reliever or rescue therapy, normal lung function, NFE1 and peak flow, and no exacerbations. Of course, there are objective tools like the asthma control test and the GINA-defined symptom control test, and various validated tools in which we can have an objective measure of the degree of asthma control, whether it's well controlled, poorly controlled, or uncontrolled. Once we encounter such a patient, what should be going through our mind? The first and foremost is this asthma? And in the previous talk, Niranjan explained in detail how to objectively assess asthma, take a history in asthma patient, and take a history in asthma patient and objectively assess using parameters like peak flow measurements and spirometry. The next thing that would go to your mind, is this not asthma? If this is not asthma, is it something else? Is it an interstitial lung disease? So careful clinical examination of the patient, auscultation of the bases for end-inspiratory crackles, like in interstitial lung disease, heart failure, would suffice? And also, could this be COPD, occupational history, smoking history, and could this be asthma COPD overlap, valvular heart disease? All this should go through our mind. If this is asthma, then is the patient on optimal asthma control? You will have a talk following my talk on asthma management. In this, Sumedha will explain in detail on what stepwise management of asthma. So I'm not going to talk to you about that. Then very important is the patient compliant with treatment. In response to Dr. Afla's question, Niranjan stated some very valid points. When a patient presents with exacerbations, how would you discharge this patient? What is your discharge plan? What your discharge plan should be? And the importance of self-management plans. So it is important that various things like the inhaler technique, which you'll hear, there's a subsequent talk on this, the compliance with treatment, proper understanding of the inhaler medication. There are the different roles of the preventer and the reliever. All this should be taught to the patient because, as mentioned before, this is a chronic disease in which partnership with the patient is essential. Then has triggers been adequately addressed, like smoking, environmental tobacco smoking exposure, domestic and occupational exposure? Are the patient, is the patient on any drugs like beta blocker eye drops that's making asthma control worse? Are there comorbidities which haven't been adequately assessed, like allergic rhinitis, gastroesophageal reflux disease, sinusitis, obesity, and obstructive sleep apnea? I will spend a little more time on comorbidities in my subsequent slides because I feel that it's important. Is this a particular phenotype of asthma? You know that most of the asthma, 90% of asthma is concordant, inflammation, and symptoms go in hand, but about 10% of the difficult to treat asthma symptoms are discordant. So according to these symptoms, according to clinical presentations and objective measurements, and the dominant type of inflammation, whether it's a Th2 dominant or Th2 low inflammation, we can cluster these patients. Or is it a particular type of asthma, like fungal sensitized asthma, aspirin sensitive asthma? Are there any triggers like that? And Niranjan mentioned exercise-induced asthma and exercise-induced bronchoconstriction and how to objectively assess this. Is this asthma overlap, or is there coexisting other conditions like overlaps with COPD, asthma COPD overlaps? Is there bronchiectasis? Is there allergic bronchopulmonary aspergillosis? Is there Churg-Strauss disease or eosinophilic granulomatosis with polyangiitis? And most importantly, is this one of asthma mimics, or does dysfunctional breathing or vocal cord dysfunction coexist with asthma? So this, Niranjan spoke about it. Asthma symptoms, as we know, chest tightness, wheezing, difficulty in breathing, limitation of physical activity, and cough are the cardinal symptoms of asthma. Not particularly of asthma, but many diseases can mimic this, like COPD, heart failure. But in asthma, in the majority of patients, they have a pattern. They are episodic in nature. They have diurnal variability, and there are triggers and relieving factors. So the importance of peak, and there may be associated allergic rhinitis, a family or childhood history of atopy. So there are objective measures, which Niranjan explained, about peak flow measurements for a period of time, and how to get an average and calculate variability, spirometric assessment, exhale nitric oxide measurements, and serum Ig, which are like which are surrogate markers of atopy. Again, stepwise management of asthma. I'm not going to talk on this because there is subsequent talk on this. Then the control of triggers, very important. Is the patient adequately aware of asthma triggers, and have asthma triggers been adequately addressed? The triggers may be allergens like dust mite, cockroach. A cockroach allergen is very important. Mold, fungal allergens inside our houses, in our walls, on our walls, washrooms. There may be mold infestation, and that is very important. And cockroach allergens, and as you know, soft toys and other things which can harbor dust mites. We have seen that even not really children, but adult girls also have soft toys, and I have encountered many instances where they have soft toys. So the longest record, the oldest girl I've seen with a soft toy is 28 years old. It's a little bit embarrassing to ask them, but I keep asking them because they do have soft toys, and they find it like a emotional bond or something to this. So it's important that you ask for triggers. And of the occupational triggers, the traditional occupations like cinnamon tappers, tea blenders, the tea fluff, coir industry, we know about. In addition, There are more modern industries like hairdressers, a common group of people whom we see. Salons have a lot of chemicals, perchlorate, persulfate, chemicals used in bleaching, and acrylic gum used in nails. And I have seen painters, professional painters, even children. Once there was a girl who came with paint on her hands, a child actually, she was about 10 years or maybe around that. And I asked her how the paint got in, and she said she's a painter, and she used acrylic as a media for painting. So as I said, 28% of new onset adult asthma are occupation related. So it's very important that you ask for present and past occupations and any hobbies that your patient may be indulging in. So you will have a talk on inhalers and the importance of inhaler techniques. So I'm not going to spend much time on it. So my main focus would be on asthma comorbidities. Comorbidities are an important feature of asthma and asthma management, and it's important that you assess patients for comorbidities. The commonest would be allergic rhinitis and sinusitis, and then gastroesophageal reflux, obesity, obstructive sleep apnea. Of course, the other things that may coexist, like hyperventilation and vocal cord dysfunction. So the evidence linking asthma and allergic rhinitis, there is this theory of one airway from the nose to the bronchi. The inflammation in the type 2 asthma is similar. It's atopic triggered type 2 dominant inflammation in which mast cells, eosinophils take part. Nasal challenge tests have been shown to produce asthmatic inflammation in the airways and vice versa. Allergic rhinitis affects about 40% of asthmatics, and majority of then about 40% of people who have allergic rhinitis subsequently go on to develop asthma. People believe in our culture especially that treating allergic rhinitis may precipitate asthma. This is not true. Anyway, whether you treat allergic rhinitis or not, 40% of those who have allergic rhinitis will subsequently go on to develop asthma. And as you know, uncontrolled rhinitis can have significant impact on quality of life. So all parameters of asthma, like asthma attacks, use of corticosteroid doses, unscheduled doctor visits, specialist reviews, emergency visits, hospitalization, are all increased in patients who have allergic rhinitis plus asthma than asthma alone. So allergic rhinitis is a significant comorbidity and should be assessed in all patients. Also, treatment of allergic rhinitis, there is trial evidence for this using drugs like nasal sprays, steroid nasal sprays. Montelukast shows better outcomes in all parameters of asthma control. Again, non-allergic rhinitis or perennial rhinitis, where patients which are triggered by occupational and other exposures causing nasal blocks can give rise to asthma symptoms. And when your nose is blocked, you tend to breathe through your mouth, and a large allergen load may enter your airways, triggering an asthma attack. Post-nasal drip syndrome, characterized by phlegm in the throat, throat clearing, a cough that happens when you are lying down, may be due to several reasons. It may be due to allergic rhinitis, it may be due to non-allergic rhinitis, sinusitis, it may be due to gastroesophageal reflux. To differentiate whether it's sinusitis or rhinitis, sinusitis is predominantly blocked symptoms, congestion, purulent secretions, facial pain, headaches, anosmia, whereas allergic rhinitis are predominantly runny, itchy, sneezing, and involvement of eye, allergic conjunctivitis-like symptoms. So gastroesophageal reflux may be acid reflux or non-acid reflux. The classical acid reflux will have heartburn, acid brush, and regurgitation, whereas the non-acid reflux is mostly postural. It's a disorder of the gastroesophageal junction, where posture and eating soon after meals, erect posture, getting up in the morning, and you start coughing. Cough is a predominant symptom in this. In patient with asthma, if cough is there, usually when you start treatment in a patient with asthmatic, all the symptoms like exercise tolerance, asthma control improves, but cough may take a longer time to improve. It may take at least 4 weeks to improve in spite of good asthma treatment. So, and it may have other reasons like allergic rhinitis, a postnasal drip, or reflux as a cause of the cough. So more than 60% of asthmatics have gastroesophageal reflux, and sometimes patients with gastroesophageal reflux, especially nocturnal acid reflux, mistake it for asthma attack, and they may take their reliever medication, salbutamol, and this will cause further relaxation of the gastroesophageal sphincter and worsen your asthma control. So it's important that your patients are able to understand that reflux, to differentiate reflux from poorly asthma control symptoms, especially when it comes to nocturnal acid reflux. So anti-reflux therapy and fundoplication have had uniformly good outcomes in patients with reflux-related or if reflux is a comorbidity of patient in asthma. Another condition that we see, laryngopharyngeal reflux, where basically pepsin content of gastric juices goes all the way up to the larynx, pharynx, that area, causing inflammation. And pepsin is a proteolytic enzyme causing inflammation, edema, and hypersensitivity of the laryngeal area. So such patients may have cough, postural cough, and cough choking. Sometimes they present with the inspirated stridor. They go like like that and choke, and then they are mistaken for asthma attack, and they are nebulized frequently. So it's important to realize that laryngopharyngeal reflux can coexist with asthma and can worsen asthma control, and be mistaken for poorly controlled asthma. And as I said, like using salbutamol, using bronchodilators, nebulization to treat this particular condition may actually worsen it. So there are strong links between gastroesophageal reflux and asthma, and strong evidence, physiological and other evidence like pH monitoring, esophageal pH monitoring, trials of treatment that treating for gastroesophageal reflux with adequate dose of PPI and antimotility agents, and in the instance of silent reflux, allogenates like antacids will help and improve asthma control. There are close links between obesity and asthma. Those who are obese and have a higher BMI have a 12% chance of having asthma, and there is close links between asthma, waist size, obesity, and asthma. This may be attributed to systemic inflammation that occurs in the obesity, and also causing a more neutrophilic-like picture in which patients have a lot of symptoms, but airway inflammation is not much, and it may be in fact a particular phenotype, because we see females in their third decade of life, obese, emotional issues, like polycystic ovarian disease, who come with poorly controlled asthma, lot of symptoms, minimal inflammation, and difficult to control asthma. Again, gastroesophageal reflux, again, there's, as I said, there are physiological evidence. This is more vagally mediated effects, and microaspiration of food particles causing airway hyperresponsiveness and contributing towards poorly controlled asthma. Smoking and asthma has close links. Smokers who have asthma or even exposure to passive smoking causes increase in asthma symptoms and poor outcomes uniformly. There is physiological evidence that there is a switch in your glucocorticoid receptor types in those who smoke to a more beta type of receptors. Some pro-inflammatory cytokines are increased in smokers, and this enzyme HDAC, or histone decyclase 2, which is necessary to switch the pro-inflammatory switch off the pro-inflammatory mediators in asthma, is inactivated by smoking, and even exposure to passive smoking can do that. So if somebody at home smokes, if a child has asthma, even that can confer steroid resistance to patients with who are with asthma. Again, aspirin-induced asthma, difficult to diagnose. They have this triad of nasal polyps and allergic rhinitis and asthma. Majority have NSAID intolerance also. It may be because of interference with the cyclooxygenase pathway, difficult to diagnose except from the challenge test. Estimation of urinary leukotrienes and things are not uniformly available as diagnostic tools. Fungal sensitized asthma, a point of particular interest to me, and I feel that this plays an important role in a country like ours, where humidity, moisture, fungal allergens are there. Yes, the day before I saw a nurse from neurotrauma. Neurotrauma, if we have visited that, we know that's full of fungi. And if you do a serum as fungal and sensitization in these people, or even a skin prick test, would be an interesting study to see how many people are fungal sensitized. So we have the walls full of mold, aspergillus and all kinds of mold. So fungal sensitization plays a key role in asthma, and there are evidence that in the fungi, the fungal wall contains diacetyl and chitin, which are strong potent allergens. And the cockroach and the cockroaches also have a carbohydrate exoskeleton, which has chitin. So it is a strong mediator of type 2 inflammation and airway hyperresponsiveness in these patients. So fungal sensitization is a big spectrum ending from endomoles to allergic bronchopulmonary aspergillosis. So fungal sensitized asthma have worse outcomes than in the normal asthmatics. Thunderstorm asthma is also interesting thing. These patients, our patients uniformly come and say during the rainy season that they get their asthma attacks become worse. This may in fact be due to the humidity, lightning, causing a disruption of grass pollen and fungal spores and breaking them down into smaller particles, giving rise to a high burden of aeroallergens in the environment. And this may trigger asthma attacks, and it can give to worsening outcomes. In fact, there have been epidemics of asthma exacerbations during thunderstorms. So again, the end of the spectrum of fungal sensitization, allergic bronchopulmonary aspergillosis, which has diagnostic criteria described by various groups. Basically, it's asthmatic who develops sensitization to aspergillus, IgE mediated, total IgE levels are high, aspergillus specific IgE levels are high, and skin prick test becomes positive to aspergillus. Fumigatus is the main culprit, but we have seen Niger and other fungi also being sensitizers and can give rise to bronchopulmonary aspergillosis. The radiological hallmark is central bronchiectasis, but we see this thick mucus, bronchoceles, dilated bronchi, and what we call the finger in glove appearance. Tropical pulmonary eosinophila are not seen very commonly now, but that sensitization to the filarial larvae can give rise to asthma-like symptoms. They have high Ig, high viral antibody titers. The absolute eosinophil count is in excess of 3,000, and the percentage is usually around 18%, 20%, not the 12%, 9% that we see in asthma and allergic rhinitis. They have radiological changes, right? Reticular nodular changes, constitutional symptoms, and a trial of diethyl carbamazine will alleviate symptoms and respond. As I said before, asthma can be concordant in most of the time, where inflammation and symptoms go hand in hand. But there are instances in difficult to treat asthma where the symptoms are discordant, where your symptoms are disproportionate to the airway inflammation, and the inflammation may be of a different type, a prosogranulocytic or more neutrophilic type of asthma. So it's important to identify these phenotypes. With your management strategies will differ. I'm just going to put you one slide on this because you have a subsequent talks on this. Those who have a Th2 dominant phenotype, who are more allergic, who are more atopic, and periostin has been proposed as a biomarker of this. I don't know whether it's commercially available. That these patients, if they don't respond to your inhaled steroids, your LABA-LAMA combinations, you may have to go for anti-IgE, IL-4 receptor, and IL-5 antagonist, and the MABs, the omalizumab, and drugs of that nature. And those who are more prosogranulocytic, Th2 low asthma, who have a more neutrophilic type of asthma, who are not atopic, these patients will have to go down a different pathway where macrolides, and in some patients in whom there is smooth muscle hypertrophy, bronchial thermoplasty will be involved in management strategy. So it's important to understand clustering of these symptoms in difficult to treat asthma, whether these patients' symptoms fall into a particular cluster, clinical symptoms, and whether there are objective measures and markers of Th2 and Th low markers are present in these patients when deciding on your management strategies. So important two reasons that I said before, where symptoms can mimic asthma. So vocal cord dysfunction, previously called vocal cord dysfunction or paradoxical vocal cord movement, now called inducible laryngeal obstruction, because the obstruction can also be subglottic. So they present more with inspiratory symptoms, stridor, difficulty in the inspiratory phase, tightening sensation in the throat. So they have these symptoms. They present to outpatient clinics and emergency units, and these patients are nebulized, and when the auscultation of the chest, they don't hear much wheeze, but they have these symptoms. So there are objective tools that you measure to measure this, like the Lancashire scale of vocal cord dysfunction, where it's a 8 item score with 5, and if you I think 12 items, a score of more than 12 would signify vocal cord dysfunction. What happens is the vocal cords adduct paradoxically during inspiration and expiration. causing difficulty in the airflow across your vocal cords. This can be objectively seen in a flow volume loop where the inspiratory, there's flattening or biphasic inspiratory curve in these patients. But if the patient doesn't have symptoms at that time, it may be normal. And again, in such patients, the ideal test would be to do an exercise challenge test and look for paradoxical vocal cord movement during the test. Another instance that we are seeing a lot of these patients during this post-COVID and COVID period presenting with difficulty in breathing, and they have been variably prescribed inhalers. Usually they say they complain about usma ganna bahe, I can't breathe, I have difficulty in breathing, I feel the air that I'm getting is inadequate. My chest doesn't get filled with air doesn't freely move into my lungs, so there is a sensation of air hunger, not enough oxygen, I'm not getting enough oxygen. And there is a feeling of restriction of movement of air to the chest, that the chest does not fill completely with breathing when they breathe in. If you watch them carefully, you will see that their breathing patterns are different. They use their accessory muscles, they sigh, they yawn, they are very agitated, or they are very uncomfortable. So frequently they are given inhalers and things, but you have to see whether this is a dysfunctional breathing or a breathing pattern disorder. There are various tools like the Nijmegen questionnaire, which is mostly to measure hyperventilation, which is only about 20% of dysfunctional breathing. As I said before, this patient present with symptoms of air hunger and symptoms of restriction of movement of air. So there can be various breathing patterns which are thoracic dominant, which they have more of an apical type of breathing pattern using accessory muscles. There's thoraco-abdominal asynchrony, where their thoracic cage and the abdomen doesn't work in synchrony. And sometimes they come and say that air escapes without knowing, a breath escapes from them without knowing. So in such instances, this may be due to predominantly a dysfunctional, discordant type of breathing. So it's important to recognize this pattern because it may mimic asthma, and it may also coexist with asthma. So there are various objective tools like manual assessment of respiratory motion, where you look for thoraco-abdominal asynchrony, and the ideal tools would be cardiopulmonary exercise testing, in which you can measure hyperventilation and a disordered breathing pattern during exercise challenge. Right. So the treatment of these would be mostly with the physiotherapist and allaying anxiety and other related symptoms. And various breathing techniques like Butenko, and training them for diaphragmatic breathing. Right, so this is our patient who had this disordered breathing pattern. She was a visitor, Sri Lankan, but she lived in New Zealand or Switzerland, and she had this disordered breathing pattern, where objectively assessed using the Nijmegen questionnaire, hospital anxiety and depression scale, vocal cord questionnaire, and breathing patterns all showed high scores on them, which is not good. And after physiotherapy, the trained physiotherapist, she did quite well. So to summarize what I have been talking about, asthma is not a uniform disease. Where there are other overlaps with asthma, and there are coexisting comorbidities which impact asthma control. So it's important when you see a patient with uncontrolled asthma, you have a structured approach to this patient, and you have all these boxes in your head, and you tick the boxes while assessing this patient. Otherwise, you will be burdening the patient with unnecessary inhalers and medication that may be, in fact, in some instances, be detrimental. So your management will depend on your assessment and your underlying cause. And it's, as I mentioned before, it's important that you have a structured approach in managing this patient. Thank you.
Thank you, Dr. Amita Fernando. Are there any questions from the audience? So I would like to ask a question from you. Now we know there are many triggers, identified triggers with asthma. Do we have facilities in Sri Lanka to identify those triggers objectively?
We have the skin prick test, we have the total IG assessment, and also you can do IG assessment to this thing. But as I said, the skin prick test is mostly confined to the private sector. I think few centers, I think Candy may be doing. We did at one time at the chest clinic, but then because of resuscitation facilities and all, we couldn't continue with that. The Dr. Rajiv and his team from MRI came and did it, but we had a bad experience once, and because we are mostly outpatient clinic and we didn't have resuscitation facilities and all, that was discontinued. But I think it is important to have this, especially in allergic rhinitis, and I think it is time that we considered introducing sublingual immunotherapy, because as we all know, allergic rhinitis is a significant comorbidity, especially in children, disrupting education and productive school life. So I think at some point in time we should introduce sublingual and subcutaneous immunotherapy, especially not for asthma but allergic rhinitis. And I think there is instances where now we are going to IgE will come, no, anti-IgE and will come. So the biosimilars will be made available. I don't know with the current scenario how it would evolve, but there are attempts they are taken to bring this medication to Sri Lanka.
Thank you, sir. So,
in fungal sensitized asthma, is there a place for itraconazole?
Yes, there is. I think there is a place for itraconazole. Sometimes patients who have difficult to treat asthma, who have high IgE levels, skin prick test may be sensitive, but this Alternaria, Cladosporium, and all this Indomold, right? A trial of itraconazole is worth giving because we don't have the anti-IgE as yet. So sometimes I do give a trial of itraconazole to these patients, about 6 weeks of itraconazole.
So in the absence of any more questions, so I would like to thank Dr. Amit Fernandez for that excellent lecture.
Thank you.
So we'll move on to the next lecture. All right. So before that, before that, I would like to hand over a certificate of appreciation for the lectures. So next lecturer will be introduced by my co-chair, Dr. Afla.
Right. So after that technical glitch, we want to get back to the next speaker, Dr. Sumedha Samankanta, who is a consultant respiratory physician at District General Hospital, Pulmonologists. So Dr. Sumedha will be talking to us from all the way from Pulmonologists about long-term management of asthma. So over to you, Dr. Sumedha.
Thank you very much, Afla. And thank you, my college and the president and the council, and also Tushar for giving me this opportunity to talk to you on this important topic. Hope you guys can hear me well and see the screen as well.
Yeah, you can go ahead.
Okay, right. Sorry about the technical bit. So we heard a lecture on how to diagnose asthma and how the clinical application of asthma, and then we went on to listen to the difficult to control or uncontrolled asthma. So the gap was left to know how to manage the standard management of uncomplicated or the long-term standard basic management of asthma. So going by this year's theme, so hopefully this gap which happened due to the technical issue, but I'll try to fill up the gap at least now. Right. So long-term management of asthma, asthma is a long-term disease, a chronic disease. However, unlike many other chronic diseases, with a comprehensive plan of care involving the patient, it can be very well managed, and mostly it can be for the most of the time with adequate training, knowledge, and support. Patient, he or she herself can manage asthma even by themselves most of the time. So there are it is not one size fitting all. It needs to be tailor-made to each individual that we meet. So there are so many components that we need to address when we are managing asthma in the long run. So I'll be talking about the goals of asthma management as being identified, as well as the model of delivering this asthma care by given to us by Gina, which is assess, adjust, and review, which need to be done in cyclical manner. So it will include the medication as well as non-pharmacological management and assessing and managing the comorbidity. So what will be when we diagnose asthma and the patient, now we have confidently diagnosed asthma, and then we are starting the management. So we have to have our goals in our mind. So what should be the goals in long-term management of asthma? So we obviously need to achieve good symptom control, and if the symptoms occur, we need to be able to relieve the symptoms. So control and relieve, and then minimize risk of exacerbations and asthma-related hospital admissions and airway remodeling, which will lead to persistent airflow limitation. Also, as we are using many medications, we need to, one of our goals should be to minimize the side effects as well. So those will be our goals of management when we think about long-term management of asthma when we meet our patient for the first time. So how do we go about delivering this management? So there is this model which we call assess, adjust, and review response cycles. So where we manage the patient in a continuous cycle. So we meet the patient, we first assess the patient in many components of the patients, the disease, the side effects, the lung functions, and what are the goals of the patient, the preferences, all those things need to be assessed. And then, depending on our assessment, we will adjust, or we will prescribe, or we will give whatever the management that we need to give. And then once we have done this, then the next step of the cycle, we need to review how the patient has responded, and then again go back to the step. So it's in a cyclical manner. So this is the personalized asthma management cycle of care, what I mentioned. So it is from Gina. So first step will be the confirmation of diagnosis. So the first lecture we had how to confirm the diagnosis of asthma. Then we need to assess about the patient symptom control and the risk factors and comorbidities, and then how the patient will be taking their medication and their knowledge. So the first step is to assess the control of asthma. So you meet your patient for the first time. I hope this is clear. The first step is to assess the symptom control. So it's simply clinically you can assess the symptom control by asking few questions, actually 4 questions. So what about the daytime symptoms? What about the nighttime symptoms? And then do you have to have you had to use your reliever how many times? And then any limitation of your activity. So if you have it's quite simple, just 4 questions you ask the patient in your clinic. And depending on the answers, if there's none of these, you consider the patient as a well-controlled asthmatic. If they have 1 or 2 of these, we call it partially controlled. And then if 3 or more of it, the questions are answered as yes, you consider as uncontrolled asthma. This is important to know at the very beginning, because your treatment, your prescription, where you place your patient in your asthma management step will depend on this symptom control analysis. Then the next step will be you have to analyze whether there are risk factors for poor asthma outcome. So there are risk factors like low reduced FEV1, or the use of many medications, having side effects of medications, and also there are certain things like comorbidities, which which Amita sir discussed as well. So whether the patient is having comorbidities like obesity, rhinosinusitis, GORD, and things like that. So also the patient's social, the socio-economic status as well as psychological status is also very important for us to know how difficult it will be for the patient to, or for us to manage the patient well. Okay, so you assess the asthma symptom control and then assess risk factors for poor outcomes, and with that idea, you go on to provide the necessary the treatment. So then comes the, so you know now that this patient is having either controlled, uncontrolled, or partially controlled asthma. Patient is having certain comorbidities as well, and there are risk factors of poor asthma outcomes. And with that in mind, you go on and try to treat these patients. So treatment, you have a few modalities. So the main modality will be, of course, the pharmacotherapy, and there are equally important non-pharmacological strategies, and then education and skills training, particularly about self-management, and then the risk factors. If you have found out modifiable risk factors or comorbidities, you have to address those as well. So coming to the pharmacological or the medication, so we have three types of pharmacological therapies that we use in standard asthma management. So we categorize them as controllers, relievers, and add-on therapies. So what are the controllers? The controllers, they have inhaled corticosteroids, so which control the symptoms, so which prevent you from getting exacerbations. It controls your asthma. So you have how the inhaled corticosteroids do this is they reduce airway inflammation, they reduce the risk of exacerbation, even when the patient is having at a milder degree of asthma. So, and also it reduces the risk of asthma related deaths. Then we have the relievers. So relievers we usually used to quite some time back. We used to have relievers as the short-acting beta agonists, but now we have what we call the ICS formoterol as well, which we call steroid-containing or anti-inflammatory relievers. So the treatment is shifting now, or already it has shifted from SABA as the reliever to the air or the anti-inflammatory reliever, because it has been demonstrated it has many benefits, and SABA has more unfavorable outcomes if used as the reliever. Right, then the other category of drugs that we have, the pharmacotherapies, we have the leukotriene receptor antagonist, your montelukast. Then we have long-term, long-acting antimuscarinics, tiotropium, sublingual immunotherapy, controlled release theophylline. This is out of the guidelines now because of the side effect profile, and which they have failed to demonstrate significant benefit, but it's an option if you do not have the other medication still, right? And for adults, azithromycin has come into the picture, and we will learn in a future lecture about biologics. So these things are the add-on therapies that we have to manage the other type of the third type of medication that we have to manage asthma. But these are, of course, most of the time reserved for the patients who are having difficult to treat or severe asthma. So how do we go about prescribing these medications? So there are, as we all know, there are stepwise treatment where we need to go step up and step down as the patient gets the control. And there have been two tracks from last year onwards. Initially, we had only the 5 steps, but now they have 2 tracks. They have separated these 5 steps into two tracks depending on what is the type of reliever that you are using, right? So this is the again from Gina. These are the stepwise management of asthma, the 5 steps that you have. So what are the drugs that you have in these 5 steps? So you have the preferred track is the track 1, which is you use steroids, that is ICS formoterol combination as your reliever medication as well. In the track 2, you use SABA, the short-acting beta agonist, but again together with ICS. So you will notice that the SABA, the short-acting beta agonists, have gone away, so they are no longer recommended to be used as your reliever, as needed reliever in steps 1 or 2, that is uh, minimally symptomatic groups. So in the preferred track, you get in the step 1 and 2, what you give is the as needed low dose ICS formoterol, and then step 3 you go for higher doses as you go on in the steps, and in the step 5, of course, you have this all the add-on therapies like the LAMAs, sublingual immunotherapies, biologics, and azithromycin and things like that. So at each step, so as you can see, the main mode of management is the steroid inhalers, right? The other ones, the leukotriene receptor antagonists and the antimuscarinics, they can be added after step 3 at any stage, depending on the requirement and the control of your patient's asthma, right? So because the steroids are the mainstay of treatment, we need to be careful on so the side effects are minimized. We need to be careful on the steroid doses. So if you see, most of the time the patients are receiving quite the highest dose of steroids. So if for them to have the highest doses, they should be actually in step 4 or 5 of the asthma management steps. But most of the time we see these patients on very high doses, which is not really required to achieve good control. So if you see the commonly used steroids like beclomethasone, budesonide, and fluticasone, the medium dose is 500 a day. So, but most of the time we get 400 twice a day, 500 twice a day, which is of course the highest dose that is possible. So we need to be aware of these steroid doses as well, because it's the mainstay of pharmacological management of asthma. So knowing these steps, how do we decide when to start or where to start the treatment at the very beginning? Yeah? So again, depending on your symptom control, how you assess. So step 1 will be symptoms are you're getting like less than 4 to 5 times 4 to 5 days a week. So it's step 1 and 2, depending if you're using the steroid inhalers. But if you're using the SABA and inhaled corticosteroids as your reliever, then the asthma should be even more controlled, or even a milder form where you get symptoms only like twice a month. So if you're getting most of the days, you place the patient in step 3. If you're getting daily symptoms or night symptoms, you have to go up to step 4. And even after those, if the patient is having a frequent short course of steroids and all, then you will have to place the patient in step 5. So that is how you start by clinically assessing your symptom control, where to put your patient at the very beginning in either of those tracks. Okay. Right, so that is a basic overview of the pharmacological management, and there are so many other non-pharmacological modalities also to manage these patients. So there are so many components like smoking cessation, avoidance of exposures, avoidance of air pollution, allergens, and so many things. Also prescribing physical activity, breathing exercises, and weight loss, so many steps. So some of these are evidence based, so it has been shown that there is a benefit in practicing this the non-pharmacological management, but some of these are not that evidence based. However, they will have other, if not for the asthma control, but they will have other general benefits, but not sometimes not, although we commonly tell our patients these things, they may not be that evidence based. So to just go through a few of these non-pharmacological interventions and how relevant or how important they are. So we say to avoid indoor allergens sometimes, but the evidence is that it is not possible, and it's not really needed, except for a very few things. One thing is the indoor the molds and dampness. So if you address this, it has shown it has good benefits in your asthma control. But about house dust mites and other indoor allergens, it's difficult to avoid, and also it's expensive to avoid. But it does not show the very good evidence to say that it will help with your asthma control. Only exception is with regards to house dust mite in sensitized children. Okay, right. And what about the weight reduction? So weight reduction, of course, it has been shown to have a good benefit in asthma control. Again, avoidance of outdoor allergens. Again, it has not shown a good contribution to the control of asthma. But for rhinitis, this may be different, right? So many things that are there, but more the ones that out of these non-pharmacological interventions, the ones that have good evidence is getting rid of the mold and dampness in your house, and with regards to children, avoiding indoor allergen burden of house dust mites, right? And weight reduction has good benefits. Also, the noxious stimuli, so the outdoor the fumes and things, if you avoid, that also has some benefit. But others, of course, uh, it will help you with the general avoidance of allergens and the general well-being of the patient, but not really with the asthma control. Right. So it's the same. So more mainly, if you want to practice avoidance measures, it is mainly for the house dust mites, particularly for children, but other things. Clinical benefit, we have not found much of the clinical benefit. So fungi, mold, and things inside your house and the house dust mite, if possible, try and advise our patients to avoid. So that will have a clinical benefit, but not the other things. Right? Okay. So we discussed about the pharmacological management and the non-pharmacological management, and then managing, then the patients might have comorbidities. Again, with the comorbidities also, there are some comorbidities that will have benefit in asthma control, but some will have only general benefit. So there are two schools of thought and a bit of controversy. So this was discussed by Amit sir. So you have allergic rhinitis, obesity, gastroesophageal reflux disease. Those things are the common comorbidities. So rhinitis, if you control, uh, it has general benefit. So the patient will have clinical benefit of being rid of rhinitis, but how much it helps with asthma control is again controversial. Some will say there are these difference, the nose and the lung, the same epithelium, the same united airway. So problems in one airway will affect the other airway. So controlling rhinitis will have effects on controlling your asthma. But Gina says otherwise. So Gina says it's not that helpful. Anyway, so if there is comorbidities, you need to address those for the general well-being of the patient. So only if the patient is having rhinitis, you should be prescribing these your antihistamines, whatever the generation they are. Same with the GORD again. Sometimes the GORD can precipitate asthma, or the asthma medications can precipitate GORD. But how much the control of GORD helps in asthma control is again topic for debate. But if you have symptomatic reflux disease, you can treat these patients and see if there is any benefit. Anyway, the patient is having symptomatic reflux, it's you have to treat. Obesity, of course, there's no controversy. So if the patient is having obesity, either obesity related asthma or even other forms of asthma in an obese patient, if you even try to reduce the weight by 10%, it will have good benefits in improving asthma control. So that's how you manage the do the pharmacological, non-pharmacological, and the modifiable risk factor management. Then, according to your steps, depending on the control, you will have to step up and step down your treatment. Right. So stepping up, so you will step up your treatment because you consider that this patient is not having adequate control. So you want to achieve control. So you are thinking about stepping up treatment. But before stepping up, think, why is he not improving? So you're giving good medication, you are trying the non-pharmacological methods, and you are trying you're addressing your comorbidities, but you're not improving. You're thinking of stepping up treatment. So revisit your diagnosis, confirm the symptoms. Symptoms are due to asthma, correct whatever the modifiable risk factors and see if that helps, and if not, you can certainly go on to the next step of your treatment. Then what about stepping down? So you don't, if the patient is well controlled, you can think about stepping down. But again, you don't need to rush to do this. So take your time. You have to keep the patient at least in the same step for three months and see if he's responding well, and then consider stepping down as a therapeutic trial. That means you step down, and see if the patient remains in good control. If not, you can always go back and choose an appropriate time. Don't try to change your medications in inappropriate times, like the patient is about to travel somewhere, go abroad, or the patient is pregnant. In such instances, you should not. And what about the options of stepping down? So you can try with the halving the dose of your steroids. You can reduce it to once daily, or you can substitute it with something like Montelukast, and also your first or second steps with steroids or the ARI, anti-inflammatory relievers, or the SABA together with low dose inhaled corticosteroids. Then what about in the cycle, what about education and skills training? So that is basically empowering the patient to self-manage asthma. So you have to obviously train on the inhaler techniques and how to recognize exacerbations and what to do when to seek medical help. So that is what is included in asthma action plan. So that is a written plan which every patient should ideally receive. How to recognize good control, how to recognize when you're losing control, and how to recognize the danger signs, and at each step what to do, when to seek medical help, when to increase your inhaler doses, when to take oral medications, and things like that. So that is part of the education of the patient, which should be as an asthma action plan. So that is how we comprehensively manage to the long-term management of asthma. Right. So you go on doing these things, and then in a cyclical manner, you review, you assess, you adjust, again review, and then you find out the patient may not have patients not having good control of his asthma. Then what should you do? Then then it's a time for you to think of this as difficult to control or severe asthma, where you will need some help from. So for that, you will need to know when to refer, right? So if the diagnosis cannot be confidently confirmed, or if there's occupational asthma, if there are any risk factors for asthma-related deaths, and so many things, side effects of drugs and things, then you should consider the patient to be referred on. All right. So in summary, so asthma is a comprehensive, in the long-term management, asthma is a comprehensive, you need to have a comprehensive delivery of care. For you to help in this, you have this model of assess, adjust, and relieve cycles. And there are three modalities of asthma management: in pharmacotherapy, non-pharmacological management, and management of comorbidities. Short-acting beta agonists are no longer recommended to be used alone in adults and adolescents. And stepwise approach to management with stepping up and stepping down as required appropriately. And you need to provide personalized asthma action plans in an ideal setting, and then need to refer when appropriate. Thank you.
Thank you, Dr. Sumedha Samankanta, for that comprehensive talk. And in the absence of, do you have any questions from the audience? Okay, in the absence of questions from the audience and from the Q&A sessions, I would like to ask one question just to enlighten and to make little to show the importance of long-term management of asthma. No, Dr. Sumedha, you said the importance of allergen avoidance, especially and how challenging it is. Can you tell about the personalized management when it comes to long-term management, especially for the allergen avoidance?
So, like I said, the avoidance for allergen avoidance, the evidence is quite low that that is really beneficial. The only benefit that is shown is avoiding your indoor molds and fungi and the house dust mite again, particularly for the children. So for them, so to personalize this, you need to explore how the patient's social conditions are, how the patient's living environment is, and then, if possible, you need to demonstrate that the patient is having allergy to this particular allergen, particularly the house dust mite. So you will have to do a skin prick test or a blood test to show that the patient is objectively allergic to this allergen, and then you can advise them to avoid particularly these two allergens, the indoor molds. If you find out that the patient's house is moldy, then you can advise them to on steps on how to clean the house to get rid of the molds. And if the patient is allergic to house dust mite, then you can advise them to try and avoid the house dust mite by cleaning, keep the house free of dust, mopping regularly, trying to get rid of cushions and soft toys and things like that, which will house this house dust mite, and also covering the beddings and the pillows and things with the impermeable material. So that is how we need to try and avoid or minimize the house dust mite allergy. So that is how we will have to advise personally, but not about the other myriad, other so many allergens. We will not, we need not necessarily advise because it's not practical, as well as it's not feasible and economical also. And there's no objective benefit shown in control of asthma by avoiding these other types of allergens, as far as the evidence is there at the moment.
Okay, thank you very much, Dr. Sumedha, for that talk and for that explanation. So let us move on to the next talk. Let me ask my co-chair to introduce the next speaker.
Thank you, Afla. The next lecture will be done by Dr. Chandimani Undugodage. She is a consultant respiratory physician and senior lecturer in physiology, Faculty of Medical Sciences, University of Sri Jawaharlal. So Dr. Chandimani will be talking on inhaler therapy basics. Over to you, Dr. Chandimani.
Thank you, Tushara, for that kind introduction. And also, thank you for inviting me to give this talk on inhalers, the basics. So actually, Tushara was under the misconception that we do teach this in physiology to the medical students. Actually, we don't. So I had to do a little bit of reading to come and do this talk today. So when we talk about inhalers, we really need to think about the history of the inhalers. So actually, the inhalers can be dated as far back as 1500 BC. This is a famous papyrus called the Ebers Papyrus, and in there, this is a picture of an inhaler. So even in ancient Egypt, people believed that inhale therapy is useful, and they used to inhale stramodium, belladonna, henbane. These contain atropine. And so this papyrus talked about inhale therapy used at that time. Then moving on, in 1778, Dr. John Mudge developed this pewter inhaler. And then he is actually the first physician to use the word inhaler in his related case histories. And the stramonium smoking came about in about 1800s, 1800s in Europe and United States. So these were personalized cigarettes rolled up, and people used it to alleviate asthma symptoms. And in the turn of the 20th century came the asthma cigarettes. So the asthma cigarettes were very popular at that time. And although it contained tar and other products that are detrimental to the lung capacity and development of COPD, as people got relief by using the asthma cigarettes, so this became very popular. So these contained stramonium, again, which has similar to atropine. So it is an antimuscarinic agent. Then in 1834, Francis Ramdaj developed an inhaler for treating TB and asthma. Which he made more widely known through his publication in Consumption Curable in 1834. So he, of course, talks about this, and he doesn't really believe this works, although he used it, but this really paved the way for a lot of breathing techniques. Now, he used this in patients who are in palliative patients to aid their breathing. So this really paved the way for our current breathing techniques and incentive spirometry that we are using today. So one of the most important milestones in the genesis of a reliable treatment for respiratory ailments in the modern era is Dr. Nelson's improved inhaler. And this was first marketed with an announcement in the Lancet in 1865. And this is the Nelson type inhaler. So this gained popularity amongst a lot of people. And these are a couple of advertisements from that era talking about the Nelson's inhaler. Following this, in 1849, the emergence of the atomizers and the nebulizers came about. So the first atomizer device was developed in 1849 in France and by Dr. Buffon, and he directed a jet of water at a mineral spring against the walls of the spa at Uets to break the liquid into droplets to be inhaled. And in 1858, Jean-Cels Girons invented a portable atomizer that utilized a pump handle to draw liquid solution from a reservoir and atomize it through a small nozzle and direct it towards an impaction plate to produce a fine spray. And this is called the pulvisator. So this became quite popular and people started using this. So in April 1955, a young girl named Susie Mason was displeased with a squeeze bulb nebulizer that she used to treat her asthma and asked her father, George Mason, MD, president of the Ricker Laboratories, the question, "Daddy, why can't they put my asthma medicine in a spray can like they do hairspray?" This simple question led to the development of an important new therapy, the MDI. So in 1956, the first MDI was introduced. And this was truly the first portable and convenient inhaler that effectively delivered the drug to the lungs. And this quickly gained widespread acceptance. And this new therapy has improved the quality of life of hundreds of millions of people around the world and has saved countless lives. So moving on to the present, at present we have three main types of devices that we are using. And those are the pressurized metered dose inhalers, the dry powder inhalers, and the soft mist inhaler. So to understand the little technical aspects, let's just brush our terminology a bit. So there is something called excipient. So excipient is an inactive substance formulated alongside an active ingredient of a medication. So it contributes to product attributes such as stability, biopharmaceutical performance, appearance, patient acceptability, and ease of manufacture of the product. And propellant, which again which comes with MDI system, it is to provide the required pressure to atomize drug formulation into micron scale droplets. And carrier particles are similar to excipients. So metered dose inhalers, the first type of inhalers, these are also called aerosol inhalers or pressurized metered dose inhalers. So the medicine is in a small canister inside a plastic case and uses a propellant, which are HFAs. Now up until 1994, chlorofluorocarbon was used as the propellant, which has changed now. And one of the problems with the propellant is the GWP, that is the global warming potential. And more and more, as inhalers are evolving, there is more emphasis on using propellants with a low carbon footprint. And interestingly, the MDI with the HFA 134A propellant is use of one dose is comparable to driving a small car for 99 kilometers. So that is how much the carbon footprint is with regards to MDIs. And when we are talking about propellants, the propellant has to be safe, low toxicity. It should be accepted by the patient, non-flammable, and also chemically inactive and stable. So when the inhaler is pressed, a metered dose of medicine comes through the mouthpiece. So this is a diagram of a MDI. As you can see, I'm sure all are very familiar with it. So you have the canister, which contains the drug and the propellant. So you have the gas phase, the liquid phase, the retaining cup, the acutainer, and then the metering chamber, and the expansion chamber. So when you press, then the spray comes out, a high velocity spray. So MDIs are an intermediate between liquid and dry formulations. We'll talk about liquid formulations later. So the active ingredient is dissolved or dispersed in a pressure liquefied propellant. And upon dispersion, the propellant rapidly evaporates, and which leaves the dry agglomerates of suspended or in situ precipitated material, which forms the aerosol, and which is what we inhale. So the MDI requires good technique and coordination, and the inhaler, so you have to press down the inhaler and breathe at the same time, and spacer devices are recommended for the use with MDIs because most patients cannot coordinate properly, and now spacers are routinely recommended. So let's move on to our second group of inhalers, and which are dry powder inhalers. And these are handheld devices, and it delivers the medication to the lungs and airways as the patient inhales through it, so which is what we call breath activated. And different mechanisms are there in different devices, and we have the drugs and the carrier particle. So in a nutshell, what happens is, when you look at the drug, so you have nanocrystals and established carriers. Newer and improved ones have nanoparticles and the next generated carriers, and they go through whatever the device, we'll talk about that, and it goes into the lungs. So there are 3 DPI formulation approaches which are used by these manufacturing companies. One is the interactive powder blends of micronized active and larger carrier. So there is the active part and with a large carrier. And then you have another group where spherical soft agglomerates of micronized drug, possibly with micronized excipients. And the third group is engineered particles, typically covering a spray-dried, low-density porous particle. So these are the 3 mechanisms or the 3 formulation approaches when it comes to dry powder inhalers. And it's very important, it's really interesting actually, the drug detachment mechanism. So how does the drug actually gets in? So there are aerodynamic and mechanical based detachment forces, and the powder particles experience different aerodynamic and mechanical forces depending on the inhaler. So this is very interesting. So depending on the inhaler device, although the drug is the same, they have different aerodynamic and mechanical forces, so the lung deposition will actually change. And also the carrier particle physical properties also influence the performance of the DPI. So this was actually nicely described in this study. The aerodynamic behavior of the carrier particles varies markedly with both their physical properties. That means whatever the physical properties of the carrier particle, they used lactose in this one, and the inhalation device, significantly influencing the performance of a dry powder inhaler formulation. So this was a study done by Martin et al. They looked at DPI's aerolyzer versus HandiHaler, and they used budesonide with lactose carriers, and they used at different doses, and they compared at different sizes, different doses, and then they compared these 2 inhalers. And to see there is a difference between the inhaler device. So this is very interesting. So the capsule-based dry powder inhalers, which we are very familiar with. So these are a few images of capsular-based. So there is, all the devices have a way to open the capsule, either break it open or pierce it, and then it is, then the patient inhales it. So I thought I'll talk a little bit about the devices that are available now. So one is the rotahaler. So rotahaler is very common. It is the one I think is available in the state sector. So here these are breath activated devices, and then the capsule you can see is inserted into that little hole, and then the inhaler is turned, and then the capsule is broken, and the powder goes into the chamber, and the patient inhales it. Then this is what we call a hand inhaler. The tiotropium is available through this device, and again, so there is a place to pierce the hole, and then as the patient inhales, the drug goes into the lungs. So these are breath activated devices. Now breeze inhalers. Again, this is one is available in Sri Lanka, the glycopyrronium intercateral combination. So a breath activated device, and here there is no propellant in the medicine, and it's inserted, the capsule is pierced, and the patient inhales it. So these particular medications are only recommended to take with this type of inhaler, so which is why the inhaler device is important. And you have the turbohaler. Now turbohaler again is available in Sri Lanka. There the dry powder is not in the capsule form. It is there a drug reservoir with a rotating dosing disc, and then the turning grip is at the bottom. And as you turn, and the drug moves on to the inhalation channel, as the patient inhales, the drug moves up. So you can see there are two air inlets, one at the bottom and one at the top. And then there are spiral shaped channels. So the air column twists, and then the drug is inhaled. So this is called a turbohaler. So it delivers medication in a dry powder form. There is no propellant, and preventers, relievers, and combination medicines are available to take via the turbohaler. Then we have the AccuHaler. Now AccuHaler is again a breath activated device. So here you can see the medicine is preloaded in foil covered blister packs. So this black wheel there is like the little blister packs. And as you turn from here, you have the contracting wheel, and then the blister packs are moved forward, and there is the drug exit post. So as the patient breathes in, the drug is expelled. So before that, the strip is peeled off, and then the empty ones are collected on this side. So these are called AccuHalers. Again, it's available in Sri Lanka. Then elliptahaler. Elliptahaler is another dry powder inhaler. There is no propellant. I don't know. I don't think these are available here. And so there are two coiled blister strips, and the manifold and the holding chamber. So mechanism is pretty much the same. So dry powder inhaler types in a nutshell. So you can have single unit capsule device like the aerolyzer, the rotahaler, or you can have a single unit disposable dose. I of course have not come across this where you dispose the inhaler device as well. There are examples. Then you have the multiple unit, pre-metered unit replaceable set like the dischaler, the AccuHaler, the ellipta, and multiple dose with a reservoir like what we talked about in the turbohaler. So these are the examples of dry powder inhalers. Then the last part is the soft mist inhaler, the Respimat device. So again, this is a handheld device. Unlike the other two, the medication is in the liquid form, and it is converted into a fine mist by a compressed spring inside the inhaler. So there is no propellant. So these are very environmental friendly devices. And the fine mist comes out more slowly and lasts longer in the air than the aerosols produced by MDIs. And they leave less medication in the throat with more reaching the lungs as compared with the MDIs. So this is a Resmimat device. So you can see this cartridge is full of the drug which is in the liquid form. This is the spring I talked about, and the capillary tube, the dose release button, the mouthpiece. So then as you load it and then give it a spray, give it a squirt, so the mist comes out. And these are a couple of examples. So there are LAMA and LABA-LAMA combinations available in the Resmimat or the soft mist inhaler form. So in summary, we talked about 3 types of inhalers. We talked about the MDIs, the dry powder inhalers, and the soft mist inhalers. So when we are prescribing, we need to think actually something that we don't really take into account are the drug formulation, and then the delivery device. We think about how comfortable the patient would be using the delivery device, but sometimes our delivery device may not be really delivering the drug as much as we want to. But having said all of that, the inhaler technique and the patient compliance is of paramount. So I will leave you with this.
Well, sometimes doctors make mistakes, Anna, and you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Jerk.
Amita Fernando had a similar experience some time ago. And so I believe, having said all of that, inhaler technique is the most important aspect of all. Thank you.
Thank you very much, Dr. Chandiman, for that interesting lecture. I think you have read a lot, and thank you very much for sharing your new knowledge with us. And so, are there any questions to ask?
About the difference between fine and extra fine particles in inhalers. Is there a place in asthma? Is there an advantage of using extra fine particles in inhalers?
Do you mean in dry powder inhalers? Yes, so actually when we talk about the dry powder inhalers, if we use a particle that is very small, the important for us is for the particle to reach the lungs, the peripheral airways. If a particle is very small, even though you inhale it, it comes out. If the particle is very large, it doesn't go into the lung, it doesn't go to where, it doesn't reach where it's supposed to reach, so it leaves halfway through. So the particle size really depends on the particle size. What the ideal particle size would be where it reaches the peripheral lungs. So extra fine, I'm not really sure exactly what is the nanometer of that, but what we need to know is exactly how much it gets deposited in the lung peripheral airways. So like I said, not only the particle size, so the carrier molecule, the inhaler device and everything, it all depends on how much of it reaches the peripheral airways, depend on all of that. So I think finally, if we can compare, one-to-one comparison of each device and each one to see how much of it goes into the lungs, then that would really be the ideal one. So it being very small may not really serve the benefit, because then it will just come out.
Because there was this concept about the importance of the small airways in asthma control. When it came to meter dose inhalers, they used, I think, less than 5 microns things as extra fine particulate HFA. thinking that it may reach the small airways, and in a patient with asthma, we know that in the normal person, most of the resistance comes from the larger airways. But in the patient, in pathological states like asthma, the contribution of the small airways may be bigger, larger than in a normal person. So that's why this extra fine particulate inhalers came. But though it was discussed at the ERS from time to time, later on, this emphasis on finer particles, HFA, cyclosinide also, because cyclosinide acts locally, it acts locally converted, locally active. It's inactive molecule which is locally converted. But the use of HFA comes, the fine particulate comes with the concept of that small airways have a larger contribution to asthmatic airway resistance than in a normal person. But later on, that was not emphasized in any of the guidelines. No? And I think you can use half the dose of your the beclomethasone if it is a fine particulate one, because airway deposition in smaller airways is much greater.
A very interesting discussion. From pediatric point of view, we are using these extrafine particles, especially in neonates, that is mainly to the respiratory distress syndrome, to reach the small airways. Actually, the particle size is improved. As Sir mentioned, when we change from CFC to HFA, the particle size actually become smaller. So like beclomethasone CFC in comparison to beclomethasone CFC formulation, beclomethasone HFA, the half the dose was enough. And the particle size, especially less than 1 micrometer, as you mentioned, usually it's act like the Brownian motions, that like normal molecules, usually expirate with the expiration. So it doesn't retain in the lung. The most important size is 1 to 5 micrometer, and more than 5, especially less than more than 10 usually doesn't reach the small airway is the most important place. So I also don't know the importance in adult patient, but pediatric patients, especially neonates, we use this. It's mainly to relieve the respiratory distress syndrome. There's a place in ultrafine particles, especially steroids. Yeah, unfortunately, these are not available in our setup. The steroids, usually beclomethasone, ultrafine particles. Yeah.
Surfactant is also given similarly, is it?
Currently surfactant is given directly through tubes, but they are having a tendency to develop the BPD, chronic lung disease, so premature to the bronchopulmonary dysplasia. For that, we have to give some steroids. The problem is in small neonates, giving steroids affect their brain growth. So to compromise both, use inhaler steroids, especially even in first 2 weeks of life.
Right. So in the absence of more questions, again I would like to thank Dr. Chandimani for that excellent lecture. Dr. Afla will present you a certificate of appreciation. With that lecture, we are going to conclude this session, and we are going to break for the tea break. And we will be meeting again in 15 minutes time.
Welcome back after the short tea break. And to start our session again, I would like to call Dr. Channa De Silva, who is a consultant pediatric respiratory physician working at Lady Ridgeway Hospital for Children. And it is a pleasure to have you, Dr. Channa, to talk to us about asthma in children, and a group where we can't, we need to be more specific, and we need to be more proactive treating the asthma. Over to you, Channa.
For giving me this opportunity, as well as to giving opportunity to discuss about pediatric asthma. So as you all know, asthma in children, so asthma is the single commonest disease that causes chronic disability in children, and that is one of the major reasons to develop, or they need hospitalization due to acute attacks. And usually when we consider preschool children, about 1/3 of them have at least one episodes of wheezing symptoms, and out of these, another 1/3 continue to have asthma or diagnosed to have asthma, which need long-term management. Other thing is, over the last few decades, we have noticed there's a rising trend of asthma incidence and prevalence globally, but still there are concerns about the pediatric asthma underdiagnosis as well as overdiagnosis. So, and still children are dying worldwide due to asthma, and most importantly, they have uncontrolled symptoms and they lost their opportunities, especially as children, and their educational opportunities because of these uncontrolled symptoms. So because of that, still it is a challenge, not only in Sri Lanka, worldwide, pediatric asthma is a challenge. So what is asthma? I'm sure this has been described already as well as you know about this, but still I just want to emphasize on few important aspects. Still we see even our trainees still don't have much about this new concept of asthma definition, especially related to important concept in this new definition. So what is asthma? We follow this GINA definition. It says asthma is a heterogeneous disease usually characterized by chronic airway inflammations, and it is defined by presence of respiratory symptoms, as you know, major 4 symptoms that vary over time and intensities together with variable airflow limitations. And airflow limitations may later become persistent. So what are the important points in these definitions? It's a heterogeneous disease. I'll come to that in a minute. Obviously, as you all know, it's a chronic airway inflammation, the primary problem. And the respiratory symptoms, we have mainly 4 clinical symptoms: cough, wheezing, shortness of breath, and chest tightness. And symptoms vary over time and intensity. So this variable nature is the characteristic of asthma, because you know there are many conditions which leading to expiratory airflow limitation. That's the physiological abnormality in asthma. But it's differ like bronchiolitis obliterans in children, sometimes primary celiac dyskinesia, cystic fibrosis also might have variable expiratory airflow limitation, but asthma differ is its variable nature. It's variable over time and intensity. And other important thing is airflow limitation may become persistent. That's especially important with this remodeling. So actually, what is asthma? So we describe as a single disease, but it's a heterogeneous disease. Asthma is just a term, it's just an umbrella term which describes a syndrome with cough, wheezing, chest tightness, and shortness of breath. So it's similar as we describe anemia. Anemia is just low hemoglobin, or arthritis is just hot, red, painful joint. So it's not a diagnosis, so it's just a term, but underlying this umbrella there are different types of endotypes, the pathophysiological processes which lead into this problem, as well as the presentations, the phenotypes. So it is very important to realize, especially in children dealing with asthma, asthma is a heterogeneous disease. It's not a single disease, it's an umbrella term which describes different types of pathophysiological processes and different phenotypes. So the diagnosis of asthma is the start, not the end of the diagnostic journey. And other important thing is which asthma does the child have. If we can work out as much as possible to identify this, then we can achieve optimal management in children, especially dealing with preschools and uncontrolled wheezes in post-school or the school-age children. So it's important to have this phenotypic approach. And the problem is still there are many concerns about this phenotypic approach. Still there are questions, how practical is this? So as we know, it's an umbrella term. Under this umbrella, there are various descriptions about the pathophysiological processes. There would be allergic sensitizations and uncontrolled symptoms, airflow limitations, variable airflow limitations, and some the pathological processes leading to some abnormalities, maybe blood eosinophilia, sputum eosinophilia, as well as increased FeNO level, like that. So under this, there might be expressions of variable phenotypes. So what are the asthma phenotypes in children? So there are several descriptions about these phenotypes according to the temporal appearance, how this pattern behave in especially preschool children. This is the very famous two-zone study published in 1995 by the Fernando Martinez and a team. I'm sure you know about him. So their team has identified transient early onset wheezes. They start wheezing especially less than 3 years of age with good prognosis, usually settles when the child is growing older. And the persistent wheezes, usually symptoms started later, and usually these patients have persistent symptoms. These are the group which having long-term wheezing symptoms. And the late onset wheezes, again, in comparison to the transient early onset wheezes, late onset wheezes also can have wheezing persistently. But still, there are several challenges about these definitions, because it's very, very difficult to categorize all the phenotypes in asthma, especially preschoolers, into this type of simple groups. So because of that, currently, even though these categorizations of phenotypes still being used, but these are now, according to the current understanding, these are not 100% accurate. In 2008, the ERS task force, they have published, or they have identified two major phenotypes, especially in preschool wheezes. The episodic viral wheezes, they are having these wheezing episodes mainly with viral infections, but in between episodes they are well and they don't develop wheezing symptoms with triggers. So they are episodic viral wheezes, or multiple trigger wheezes. They are having these symptoms with viral infections as well as in between episodes with exposure to various kind of triggers. So again, this was challenged, and one interesting article published in 2011, they just mentioned this is just oversimplification of what is actually happening in preschool wheezes. And this study, the episodic viral wheezes and multiple trigger wheezes in preschool children are neither distinct nor constant pattern. This study was published in 2019. They have identified this is changing. Initially child might be diagnosed as episodic viral wheeze, but later the pattern will be changed like multiple trigger wheezes. But still, the identification of this type of phenotypes are important. One thing is to get at least rough idea about the prognosis as well as the plan of management. But still, we don't have a proper diagnosis or proper description of phenotypes in asthma. Other important thing is wheezing symptoms, whether it's actually asthma or some other things. So especially infants, the commonest reason to develop wheezing is bronchiolitis. And later, it may be this viral induced wheezes, and later the wheezing, the main cause would be asthma. So we have to have some idea about this differential diagnosis as well, especially child presenting with wheezing symptoms. So according to the frequency of symptoms, again we can assess about the mild to severe disease as well as episodic to continuous disease. According to that, we have 4 categories: mild continuous, mild episodic, episodic severe, or most severe form, the severe continuous wheezing. But still up to date, no accepted comprehensive classification of asthma phenotypes in children yet, but better to have some idea about what are the phenotypes described up to now. So Gina described about allergic asthma, which in all is typical IgE mediated type 1 hypersensitivity pathway, non-allergic asthma, especially involving the TH type 1 pathway, adult onset asthma, asthma with persistent airflow limitations, so asthma with obesity. So obesity and induced asthma, as you all know, is a different category and difficult to treat because it is mainly mediated to TH1 pathway rather than the TH2, the classical allergic induced pathway. So why these variations happen? Because when we consider this etiology of asthma, it's a combination of several factors, maybe viral infections, pre-existing airway inflammations, obviously the genetics factors, especially family history is important, especially when we're dealing with children. Sometimes the infections, bacterial infections or the colonization, the microbiome also would be important to shape the final figure of this asthma, as well as the treatment and the response to treatment. So all these things are unique to individual children because these are heterogeneous conditions, heterogeneous factors, and because of that, each child's asthma is different. So when we manage in these patients, so one of the important take-home message is we need individual approach in the management of children with asthma. So how do we diagnose? Obviously, we have to assess the symptoms of these children, the cough, wheezing, breathlessness, and the pattern of these symptoms. I am not going into details of this. And the variability is important. How this varies, it may vary according to the time of the day, temporal relationship, as well as associated with triggers. And importantly, especially when we're dealing with children, the family history of atopy, family history of asthma, as well as personal history of other atopic diseases also important. And response to controlled treatment and recurrence of symptoms, if we stop these, almost clinically confirm the diagnosis of asthma. So the diagnosis of asthma in children is still, I'm sure in the adults also, it's basically clinical diagnosis. Still, we have to consider several factors. But other important thing is, there are many differential diagnoses of asthma. Many conditions, especially in preschool versus small children, which could mimic asthma. It may be tracheomalacia or bronchomalacia, just a congenital heart disease, and recurrent viral infections can induce wheezing, but it just a viral induced wheeze might not be true asthma. And some reflux, chronic aspirations, especially children with neuromuscular disorders or Down syndrome-like conditions, structural abnormalities, bronchopulmonary dysplasia, like that. Or even some congenital truly respiratory diseases like PCD or cystic fibrosis. So it's very important, especially dealing with children when they come in with wheezing symptoms, to identify whether these children have some red flag signs which indicate other than some diagnosis other than asthma. So whether this cough is persistently moist, indicate possible bronchiectasis, underlying chronic suppurative diseases, isolated cough without wheezing, and these symptoms, if they have these symptoms since early infancy, it's very unlikely that it is due to true asthma. Significant failure to thrive, it may be cystic fibrosis, stridor, finger clubbing. So all you know these things, but it's very important to have idea about these features to identify or assess. Actually, we have to assess whether these children have these features suggestive of some alternative diagnosis. So I just show few examples which I came across during my local as well as foreign training. So this is a 3-year-old girl with recurrent severe wheezing episodes, PCU admission twice and required ventilations. Because of that, we did the further investigations, and bronchoscopy revealed narrowing of the mid-trachea, and the imaging showed it's a cystic lesions which compress the mid-trachea, leading to this almost wheezing-like symptoms or asthma-like symptoms. So this child, so-called asthma, was cured with the surgical correction. It was a bronchogenic cyst. And another 6-month-old child present with recurrent wheezing episodes, again managed as asthma, poor response to usual treatment. Bronchoscopy revealed again a narrowing of the mid-trachea, and the CT revealed the right-sided aortic arch completely encircling the almost is a vascular ring causing obstruction to the trachea, and the symptoms was like breathing difficulty and initially managed as asthma. So this child, again, the asthma was cured with surgical correction. 11-month-old baby, recent onset, 2 months of history of recurrent symptoms, wheezing-like symptoms, managed as asthma. X-ray revealed hyperinflation of the right side of the chest with mediastinal shift to the left side, and CT also confirmed hyperinflated right lung, and bronchoscopy revealed foreign body. This is a food particle impacted in the right main bronchus, causing partial obstruction and the bowel valve effect. And another 1-year-old boy, recurrent and persistent wheeze despite adequate management. So this one, bronchoscopy revealed subglottic, some this type of narrowing due to some fold-like things. Actually, these were hemangiomas causing the obstruction. So this child, actually, the treatment was propranolol. So as you know, it's contraindicated in asthma, but this child, so-called asthma, was completely cured with propranolol. So the correct diagnosis is important. And another 6-month-old baby, again recurrent wheezing-like symptoms, bronchoscopy revealed narrowing in the trachea as well as main bronchi. So if you compare with the normal trachea, you can see the difference. This is child with tracheomalacia as well as bronchomalacia. So obviously these are very rare incidents, but at least once in your life, if you can identify one child and prefer to the proper management, this might survive. You will be able to survive at least one child. So diagnosis, which is very important, the first thing is in a pediatric asthma, correct diagnosis. It is highly probable if they have typical symptoms as well as recurrent, and what I mentioned already, all these typical features are present. But intermediate possibility, if some features are present, but it's not the main features are present. Other important thing is low probability, especially if the presence of any red flag signs. These are the important group. Identify early and refer to appropriate management. So how do we confirm the diagnosis? Obviously, according to even GINA, if before starting long-term treatment, even in children, it is better to have a confirm the diagnosis, appropriate lung function test. We are using the spirometry, but the problem is it is limited role in small children, especially less than 6 years of age. Obviously, due to practical problems, they cannot do the proper the maneuver. But other thing is, obviously, negative test doesn't exclude asthma, but positive test, especially important. First thing is the confirmation of diagnosis, but other important thing is, especially when we dealing with pediatric practice, sometimes the parents are little still reluctant to start or continue the inhaler therapy, but this is very important. If we can have a proper spirometry, if we can have a proper diagnosis, then we can show the parents. So this FEV1, so these values are increased just after giving the bronchodilator. That means your child is having asthma. So this is the treatment. Like that, it's very easy to convince, therefore, even for long-term management plan. So what are the goals of treatment? Once we start treatment, so obviously it's a control of symptoms, and as we are dealing with children, to have to allow them to have normal activity without undue restriction. That is one of the important things. Usually it's our setup still. The parents, once they convinced about the diagnosis, since then start to restrict their life, in especially children, lot of restriction, even physical activities, foods, lot of things. So it's our objective is to allow them to have a normal life as much as possible, maintain pulmonary functions as well as the prevent fixed airflow limitations. So proper treatment is important because if especially children with uncontrolled or severe asthma, if we do not address these issues properly, these changes might persist and even end up with long-term conditions, and even as adults, it might be a risk for adult chronic respiratory diseases. So this study was published in 2018. Very interesting. 6 decades of follow-up since childhood. They have assessed the lung functions. They have clearly shown that if the children, if they develop lung problems, chronic respiratory diseases, and clearly there is a risk of persistently low level of pulmonary functions and the risk of COPD. So this study mainly focused on several respiratory problems. And another study published in 2013, they have clearly mentioned, especially with moderate to severe asthma, if they have these symptoms, so uncontrolled symptoms, the lung functions would be persistently low as in when adults. So it's very important to treat it properly to prevent these long-term effects as well. It's not only the managing asthma in children. Other thing is, obviously have to reduce exacerbations, and finally we have to assess, or we have to gather all these effects with no or minimum adverse effects. So these are the goals of management. So because of that, obviously, as you all know, we are using this stepwise approach. Appropriate step we manage without under managing or over managing, and it's obviously we follow this GINA the management guidelines, the review the response, assess and adjust the treatment. So because of this, we mainly follow this stepwise approach. 5 steps, you are very familiar about that. There are no major changes of children and adults, but few changes, especially the drug combination. So the choice of drugs, especially preschool children. Obviously, the step 1, controller intermittent short course of inhaler corticosteroids, as earlier presentations also mentioned. Now we are gradually getting out of giving only the short-acting bronchodilator, because asthma is inflammatory condition, so we have to treat the inflammation, not just a bronchodilator. Even in preschools now, this has changed in this 2022, the latest guidelines, they have very clearly mentioned, because initially, the less than 5 years, they didn't focus about that, but now, whenever the short-acting SABA is required, so it's better to give inhaled steroid as well. Another important difference in small children is still we don't have proper evidence about the safety of long-term use of LABA, even though we use practically, but studies are lacking. So because of that, we don't have convincing evidence of the safety of using long-term LABA, because LABA obviously can cause downregulation of these beta-2 adrenoreceptors. Because of that, it might cause various things. Even LABA can act as a pro-inflammatory mediator. So because of that, still there are concerns. So the step 2, mainly we are using the inhaler corticosteroid, and if we want to step up, the preferred method is double the inhaler corticosteroid dose in step 3, but other age groups usually we do add in LABA in step 3. So the 6 to 11 years, the same as older children. There are no major difference except the smart therapy, the MART therapy, the maintenance and the using single inhaler for the maintenance and reliever therapy, that is mainly recommended still over children over, or the adolescents over 12 years. But otherwise, these steps are almost same in children as well. So the MART, so this is again the important thing getting little popularized. So because this improve the compliance, as so use a single inhaler, the most important thing is using formoterol. So formoterol, the onset of action is little short. So because of that, it's almost act like the SABA, short-acting bronchodilator, or the salbutamol. So other thing is, if they are having some exacerbations, if they want to take more SABA, so using this smart therapy or the combined inhaler, it gives additional steroid dose as well. So that improve the symptoms as well as the prevent the requirement of a severe exacerbation or requirement of hospitalization, as well as use of systemic steroids. So that's the main important thing, prevention of the requirement of systemic steroids, because we are giving small doses of inhaled steroid with this smart therapy. So the inhaler techniques, so following very interesting lecture about the inhalers. This inhaler technique is very important because especially children, the proportion of lung deposition is the most important thing. So it's divided on the type of device, aerosol formulation, and the inhaler techniques. Because it's the particles deposited in the small airways with 3 mechanisms: the impaction, sedimentation, and diffusion. So we don't have time to discuss in details. The impaction is the larger particles directly impacting the larger airways, and the sedimentation is because of this gravity effect, they deposit, the small particles deposit in the airways, the small airways. So the most important thing is the sedimentation. And the diffusion, the smaller particles less than 1 micrometer diameter, it's usually act as usual molecules with the Brownian motions. Some of them absorb. So as you know, the airway, it's divided into 23 generations. So divide. So the particles should reach the small airway as well. So because of that, if we don't do, so the particles, the larger particles retain in the oropharynx, the small particles, the important thing, and the focus is the particles 1 to 5 micrometer diameter, maybe 2 to 5. There are little changes, because if we don't use it properly, 95% of the particles solute and give rise to the side effects. Only 5%, 5 to 10% reach the lung. So this is the most important thing using these inhalers. So what is the best long-term method for children giving these inhalers, so the long-term steroids or the bronchodilator agent? So this very interesting summary published in 2017. So you can clearly see this. Sorry. Right. This red color thing is the oropharyngeal depositions. With pressurized MDI alone, significant proportion deposit in the oropharynx, small proportion in the lungs, the blue color portion. And if you add the spacer, significant proportion of this unwanted fraction deposit in the spacer. So the side effects simply go to the spacer, right, and not the pharynx. So the person who inhales, the pharyngeal deposition significantly reduced. If we use a proper valve holding chamber, so this is the best method using the spacer that you are using. The term is a valve holding chamber. So it maximizes the lung deposition and it minimizes the pharyngeal deposition. So there are old studies that prove this concept with using technetium label particles. And so you can clearly see if we use a spacer, the unwanted large particles retained in the spacer and the lung deposition also will be improved. So this one very clearly show that. So these unwanted particles, larger particles retained in the pharynx and swallowed give rise to the side effects. But if we use a spacer, these unwanted particles, the larger particles retained in the spacer, but the lung deposition will be improved. So because of that, especially children, so MDI alone is not recommended. Always have to use with the spacer. And there are various types of spacers, inhaler techniques. As we don't have time, I'm not going to the details. So inhaler technique is important because in children we are using the multiple breath techniques, shaking the inhaler, connecting the proper way, upside down, the very tight mouthpiece or keeping the air seal, and the activation of MDI once rather than giving 2 to 3 puffs together. Each puff should be followed by 5 to 6 breaths. So all these are important. And so because of this, small children, we use the spacer plus face mask up to about 4 years, and after 4 years, without face mask spacer, they can use the mouthpiece. So always it's important to advise properly, demonstrate it, and check regularly. And the follow-up is also important. And small children, we are using this GINA guideline, and uncontrolled symptoms, so they have been already discussed, so I'm not going to the details. So finally, this important concept I have to also give, the exacerbation, so acute attack. So we have to consider acute attacks as, while managing acute attack, it's as a reason, we have to assess in especially children why this child developed this acute attack. So it's just some sort of fact-finding mission rather than just managing this acute attack. So we had changed the management. So we have to think why this child developed this problem. So always it is very important to assess all these things to prevent further acute attacks. So rather than just managing acute attack. So in the future there are many studies, many concepts are going on, especially whether we can prevent the development of asthma. That is why it's important to identify the underlying endotypes, what are the physiological pathways, as well as whether we can cure asthma, especially disease-modifying approach using biologics. So in summary, asthma is a leading cause of childhood morbidity, even mortality. We need to have optimum asthma control in children. Correct diagnosis is important, and this possible identified possible phenotypes and appropriate pulmonological management, long-term management, proper inhaler techniques, regular follow-up, and if they have uncontrolled symptoms, we have to address them properly and consider acute attacks as a fact-finding mission to prevent further acute attacks. Thank you.
Thank you, Dr. Channa, for that comprehensive talk on asthma in children. Since we are running short of time, I would like to bring up one question which was sent on question and answer forum. So the question here is, if child had bronchiolitis in the past, is it a risk factor for asthma?
Yeah, so it's like this, the underlying lung problems, so the viral infections is considered as a risk factor for asthma, but that is not the only risk factor. As I shown, it's a the outcome is with variable factors, the genetics, these viral infections, environment, lot of things. Yes, obviously the viral infections, even bronchiolitis can act as a risk factor, but obviously that is usually not the only factor.
Right, thank you. Any questions from the audience? Right, in the absence of questions, I would like to ask Dr. Tushara Galabada to award a certificate of appreciation to Dr. Chan De Silva. So to start the next talk, let me ask my co-chair to introduce the speaker.
It's my pleasure to introduce next speaker, Dr. Dinesh Dasanayaka. He is the consultant respiratory physician at Teaching Hospital, Anuradhapura. He will be talking on management of acute severe asthma. So he will join us online.
Let me share the slides for you. So I'll be joining from Anuradhapura, and I'll be talking to you on management of acute severe asthma. So before we go into details, these management steps are based on GINA 2021 guideline and National Asthma Council Australia. Before we go into management, let's see what happens in acute severe asthma. This is basically airway inflammation together with bronchoconstriction that leads to acute severe asthma. And in airway inflammation, there's inflammation together with edema and mucus plug formation, which causes distal airway narrowing, which leads to gas exchange abnormalities. And it's the bronchoconstrictions that lead to smooth muscle spasms, central airway narrowing, which causes spirometric abnormalities. Anyway, this is the first slide. So this is two pathways, airway inflammation and bronchoconstriction. Airway inflammation leads to gas exchange abnormalities, and bronchoconstriction will lead to spirometric abnormalities. So what are the features of severe asthma exacerbation or acute severe asthma? So we have learned a few things about asthma. Now when asthmatic or previously diagnosed patients comes to A&E with features of acute severe asthma, you have to recognize this as an acute severe asthma before you start managing. So what these are the features of acute severe asthma. If one or more of them are present, you can consider this as an acute severe asthma attack. What are they? First thing is use of accessory muscles of respiration, then tachycardia, inability to speak in sentences. This is a very important sign. First, when you talk to patient, you can diagnose acute severe asthma. Respiratory rate is usually more than 30 beats 30 beats per minute, and FEV1 and peak flow rate is less than 50% predicted. If you have a peak flow meter, this will be very useful, but unfortunately, most of the patients who present with acute severe asthma, they are unable to perform these two tests. So this, if the patient can perform, it's good, but if not, you go by the other clinical criteria. And saturation can be 90% or less. So before we go to management, we have to assess the patient properly. So first step is clinical assessment. You see the patient's accessory muscle use, tachypnea, tachycardia, diaphoresis, and exhaustion, which are features of acute severe asthma. Then you assess the airflow limitation by peak flow measurement if the patient can perform it. Then assess oxygenation with pulse oximetry and assess for hypercapnia. Rarely acute severe asthma and later life-threatening asthma can lead to hypercapnia. So in selected patients, you have to do arterial blood gas analysis, and if you think the patient has hypercapnia, you have to detect it early. Imaging-wise, you have to perform a chest X-ray to assess complications like pneumothorax, and blood work, full blood count, glucose level, inflammatory markers to if you consider infective exacerbation. This is basically a acute severe asthma monitoring chart. See what you can see in them. Apart from routine observation, you have to monitor use of accessory muscles and it's vital that you monitor respiratory rate. Respiratory rate is a key feature in patients who are deteriorating. The respiratory rate will go up. If the patient is improving, the respiratory rate will come down. These are the components according to the clinical features and observations. You have to decide to upscale or downscale the management steps in acute severe asthma. So what happens if you don't treat acute severe asthma properly? This slide shows the gas exchange which happens if you don't manage them properly. With moderate to severe asthma, the patient will become exhausted if you don't treat them properly, and the tachypnea will worsen, and oxygen saturation will start dropping. And because of exhaustion, there will be ventilator failure, causing rise of CO2. This rise of CO2 and drop of oxygen saturation, and the lines will cross at a certain point, which cause the crossroad of death. So the aim is to prevent this crossroad of death and to recover the patient. So coming back to treatment of acute severe asthma, there are principles and primary goals of care. The primary goals and principles are: first, to relieve airflow limitation. This is done by bronchodilator therapy. Then you treat the airway inflammation with steroids and treat hypoxemia or hypercapnia accordingly, and initiate mechanical ventilation in severe cases without any delay. So we will go one by one, these steps and goals. This is briefly the GINA guideline showing the flow chart. Hope you all can see the slides, but they are very congested. I will go them step by step. So initially you assess the patient and then decide which the severity of the exacerbation. If it is a life-threatening asthma, initially you start immediate treatment and assess for intubation and ICU care. And if it is acute severe asthma, then you initiate the next steps of management like oxygen therapy, bronchodilation, steroids, and other steps of management. So we will go one by one. What about oxygen therapy in acute severe asthma? Oxygen target for acute severe asthma is 93 to 95%, and in children, you can aim for above 95% saturation. This achieves a better physiological outcome compared to 100% oxygen at a high flow rate. And some of the patients, even in acute severe asthma and life-threatening asthma, hypercapnia can result if you give high flow oxygen. So you have to be cautious. So 93 to 95% of saturation target is enough for acute severe asthma. How do you give bronchodilator? Whether you give through a nebulizer or through an inhaler plus spacer device. There are studies done in many countries, and now we know that in the post-COVID era, MDI with spacer is preferred over nebulization because of concerns with aerosol generation. And metered dose inhaler with spacer is at least as effective as nebulizer. Therefore, you can use safely a metered dose inhaler with a spacer for acute attack. How do you give? Give salbutamol 12 puffs, one after another. One actuation is 100 micrograms. You can give one actuation and ask the patient to breathe in and out through the spacer. And after 30 seconds, you repeat the second puff. Like that way, you can give up to 12 puffs at one go. If the patient is unable to breathe through a spacer, you can give 5 milligrams of salbutamol via nebulizer. And you repeat salbutamol as needed and give at least 3 doses 20 minutes apart for the first hour. For patients with life-threatening asthma, it is recommended that you use continuous nebulization driven by oxygen until breathing improves, and then consider changing to a pressurized metered dose inhaler plus a spacer or intermittent nebulizer. When you are using continuous nebulization, you have to make sure the nebulizer changer can hold at least 16 ml of fluid. Now, most of the hospital nebulizer chambers don't have this capacity. Therefore, you have to refill in between. But you can, if you can have a nebulizer chamber with 16 ml capacity, keep it for continuous nebulization, a separate one for these type of patients. So whether you use continuous or intermittent nebulization, there are systematic analysis done in Cochrane database. What does it say? So continuous nebulization improves pulmonary function and reduces admission, beneficial in patients who fail for initial management. Therefore, it is recommended for life-threatening asthma if they have life-threatening features like confusion and silent chest. Nebulizing via a mouthpiece has better lung deposition and less adverse effects compared to mask. So this is the recommended type of mouthpiece for any type of nebulization currently. And if the patient is confused or agitated who can't hold the mouthpiece, then you can use the ordinary face mask. Advantage of this mouthpiece is it improves lung deposition and it has two valves. Therefore, it prevents any wastage of the drug as well as any complication of eliminated drugs to eyes and other surrounding. So this is the recommended mode of delivery of drug if you are nebulizing. Especially it prevents any aerosol generation and it is good for like any lung disease who needs nebulization. And there are nebulizing guidelines prepared for various units, and we use this nebulization technique in our unit as well as previously in Pulmonology we initiated this. But problem is finding this device is difficult because it's not in MSD. So you have to get it down from outside and then use it for such patients. So this minimizes aerosol generation and it improves lung deposition and improves like prevents drug wastage. Is ipratropium beneficial? Yes, it is. Ipratropium bromide may reduce admission rates and improve lung function in children and adults with acute severe asthma. This is proven in many of the studies, and there are meta-analyses again in Cochrane library. So ipratropium bromide alone is less effective. Therefore, it should be added to salbutamol in acute severe asthma. So you combine salbutamol and ipratropium together in one chamber and nebulize together with normal saline. And you have to make sure that there's at least 4 milliliters of fluid in the nebulizing chamber for effective nebulization. So this is how you use ipratropium. One actuation is 21 micrograms. Again, you can use MDI with a spacer if you can get hold of a ipratropium MDI. And every 20 minutes you use at least 2 puffs in the first hour, then you space it out for 4-hourly or 6-hourly MDI inhalation. If you are using a nebulizer, you can use 500 micrograms every 20 minutes for first hour and repeat every 4 to 6 hours. What about systemic corticosteroids? As I said earlier, main mode of pathology is inflammation of bronchial tree. So steroids is the mainstay. For adults, you have to start steroids at least within 1 hour of presentation to ED, unless contraindicated, regardless of severity at initial assessment. And dose of prednisolone we use is between 37.5 to 50 milligram, which is a very high dose. If the patient can't take it orally, you can use IV hydrocortisone 100 milligrams 6-hourly, and stat dose given at within 1 hour of arrival of the patient. And you don't have to tail off oral prednisolone if you have used only for 14 days or less. And higher doses of hydrocortisone is not necessary because it's not effective as 100 milligrams. So this is meta-analysis showing the effects of hydrocortisone. Corticosteroids within 1 hour of presentation to an emergency department significantly reduces the need for hospital admission, and benefits appear greatest in more severe asthma and those not currently receiving steroids. So this was the basis for this recommendation. So what about magnesium sulfate, which is commonly used in acute severe asthma? There are enough studies and meta-analysis again leading to guidelines on use of magnesium sulfate. So the conclusions of this meta-analysis is in life-threatening asthma or patients with poor response to initial bronchodilator treatment, that means oxygen, bronchodilators and steroids, IV magnesium sulfate given as a 2-gram infusion over 20 minutes can reduce hospital admission rates. And it's not for routine use. and only for patients with poor response to initial treatment. What about inhaled magnesium sulfate? Initially, some of the guidelines used magnesium sulfate inhaled preparation for acute severe asthma. Now the recommendation is it's not effective as IV magnesium sulfate, therefore not to be used. So if you have to use magnesium sulfate, use it as an IV infusion, not as an device. What about IV salbutamol? Again, there are enough studies and meta-analysis, and most of the studies have shown that there are lots of side effects. Therefore, the conclusion is there's no significant benefits of adults for adults with severe acute asthma, and there are more side effects. Therefore, not to be used in routine practice, only in ICU care. So, IV salbutamol is used only in ICU for life-threatening asthma, not for routine care. You can give a loading dose and then start as an infusion, and we know when breathing stabilizes. So is there a place for IV aminophylline in acute severe asthma? There are enough studies and meta-analysis again in Cochrane Library. This drug has lots of side effects, seizures, arrhythmias, and even deaths have been caused by inappropriate use of aminophylline in patients with cardiac disease. Therefore, the conclusion is intravenous aminophylline is associated with higher rate of adverse effects. Addition of aminophylline does not achieve greater bronchodilation or reduce hospital admission compared to bronchodilators. Therefore, IV aminophylline should not be used due to poor efficacy and potentially fatal adverse effects, and we don't usually use these drugs nowadays. So do you give antibiotics in acute severe asthma? So most of the exacerbations are actually driven by viral infections. Therefore, antibiotics are not recommended. But if you think there's bacterial infection which is leading to infective exacerbation of asthma, then there's a place of antibiotics. Otherwise, routine antibiotic prescription is not recommended. And in choosing antibiotics, if you had to give antibiotics for infective exacerbation, add a macrolide, because it has an additional benefit of modulating inflammatory response in asthma. So this is an important question asked every time. Role of NIV in acute severe asthma. So NIV is used very commonly in COPD exacerbation. So what do you do in acute severe asthma? Do you use NIV? This is available now in most of the hospitals. And NIV, because of COPD exacerbations, some think it has a benefit for acute severe asthma as well. But the studies have shown that there's not much of a benefit in acute severe asthma. And there's not much data to support the use of NIV in acute severe asthma according to the current studies. Therefore, the current recommendation is NIV should not be used for acute severe asthma because it can cause delays in intubation. In acute severe asthma, if the patient does not respond to initial treatment, straight away the patient should be intubated and ventilated, unlike COPD exacerbation. There's a huge difference in managing acute severe asthma and COPD exacerbation. That's one reason we should have a clear diagnosis of asthma and COPD. So this is one major difference in the management. NIV is not used in asthma, but in COPD, NIV is commonly used. So even in our guideline, Sri Lanka College of Pulmonologists does not recommend use of NIV, and it actually discourages use of NIV in asthma. So no NIV for asthma. So this is the flow chart again for asthma management, acute severe asthma. First step is you assess the patient, whether the patient has acute severe asthma or life-threatening asthma. How do you differentiate if the patient is moribund, confused, there's silent chest and drowsiness? Then you think of life-threatening asthma, then you immediately prepare the patient for intubation and consult ICU for further management. If the patient doesn't have any features of life-threatening asthma, then you assess the patient whether the patient has acute severe asthma or moderate exacerbation. If there's acute severe asthma, Then you start oxygen therapy, as I said earlier, and start on bronchodilators, salbutamol plus ipratropium plus normal saline, and 3 doses in first hour. And if the patient deteriorates, you can convert to continuous nebulization. Then give IV hydrocortisone or oral prednisolone or steroids within 1 hour of presentation to emergency department. And you can optimize the inhalers at the same time and monitor the patient on monitoring chart. If the patient is deteriorating further, and immediately consult ICU and prepare for intubation. If the patient is improving, then you can consider downscaling with monitoring to a acute side of respiratory unit, and then you can phase out the nebulization use and wean off oxygen if the patient improves. If the patient doesn't improve, then again look for the underlying cause and look for complications, especially pneumothorax and worsening pneumonia. So these are the steps in management of acute severe asthma. And going back again in summary, assess for features of life-threatening asthma. Then you bronchodilators, steroids, oxygen therapy if the patient has acute severe asthma, and consider IV magnesium sulfate. If the patient does not improve, consider intubation and ventilation in an ICU care. Prefer early for ICU care. Otherwise, the patient will deteriorate further. So this is what happens if the patient improves. Then you phase out your treatment plans and a discharge plan later. If the patient does not improve, look for complications and again reassess the need for intubation and ICU care. Thank you, and I'm happy to answer any questions.
If you have any question, you can ask. I would like to ask one question from Dinesh. Now, you categorically said that there's no place of NIV in asthma. I just want to ask you about now patients who are having long-standing asthma, chronic asthma, basically coming with an exacerbation. So, what do you think place of NIV, especially in the setting of ICU or HDU, before straight away intubating?
Yes, long-standing asthmatics can have something similar to COPD actually, and they can be having CO2 retention from the beginning. In that case, arterial blood gas analysis is very useful, which will show compensated type 2 failure. So if that is the case, then there's a place for NIV initially until you bridge the patient for ICU care. Such patients will benefit from NIV, but otherwise the routine acute severe asthma attacks, NIV has no place, or it can actually delay the intubation. Chronic asthmatics who are anyway having features of CO2 retention or chronic CO2 retention will benefit from NIV. Otherwise, no. That's what the guidelines say.
So, in the absence of any further questions, I would like to thank Dr. Dinesh Dasanayak for that excellent lecture. Thank you, Dinesh.
Thank you very much.
So my colleague Dr. Afla will introduce next lecturer.
Right. So we are getting into the complex area of asthma. So it's my privilege to call and ask Dr. Dilisha Vadasinghe, who is a consultant respiratory physician and a senior lecturer in physiology, Faculty of Medicine, University of Kelaniya, to talk about this complex area of asthma, that is refractory asthma, and especially the use of biologics.
Thank you very much, Dr. Afla, for that very kind words of introduction. And I would like to thank the college, Sri Lanka College of Pulmonologists, for inviting me for this lecture as well. So we have been listening to a series of lectures regarding how to investigate and how to manage asthma. And now I will be talking about severe refractory asthma and the role of biologics. So my talk will outline the definition of severe asthma and
briefly touch the endotypes or the phenotypes of severe asthma, and I will briefly outline the currently FDA-approved biologics for the treatment of severe asthma. So severe asthma is now previously, which was called severe refractory asthma, is not anymore refractory because of the use of biologics recently. So it is a subset of difficult to treat asthma, as Dr. Amita Fernando spoke very well in his lecture. And it is defined by the GINA team as asthma that is dependent upon high dose of inhaled corticosteroids plus a second controller, and also systemic corticosteroids in order to either maintain symptom control or asthma which remains uncontrolled despite these intense treatment. So how common is severe asthma? We have data from a Dutch population. As you can see, 24% of the asthmatics are on high intensity treatment and 17% are difficult to treat asthma out of the whole asthma cohort. So after we exclude those patients who are poorly adherent to the inhaler therapy and also addressing comorbidities, the prevalence of severe asthma was thought to be, has been estimated as 3.7% of the asthma population. So this is not a big number, but then why do we worry about it a lot? So it is because this cohort of patients accounts for a disproportionately high share of asthma-related healthcare cost, and these patients suffer from daily symptoms, they miss work, school days, and also they use the healthcare facilities due to frequent exacerbations quite frequently. Not only that, because they have severe exacerbations, they are on quite a high dose of, cumulative dose of oral corticosteroids, leading to various side effects such as adrenal suppression, type 2 diabetes, osteoporosis, osteopenia, obesity, cataracts, high blood pressure, and depression and anxiety as well. So I will not go through this slide because you have been listening to a very comprehensive lecture by Amita sir. What I would be focusing on is the group beyond the red line, which is the severe asthma group after you have done your difficult to control asthma workup. So according to the GINA guidelines, after confirming the diagnosis of asthma, so first you'll have to confirm the diagnosis of asthma, as Dr. Niranjan highlighted very nicely. And then you will have to investigate and treat the comorbidities. And if this is not asthma, then you'll have to think in different lines. And after that, we should try to see whether we can find what kind of inflammation, or whether we can put our asthma patient who is having severe symptoms into any of the phenotypes what we have spoken about. So type 2 inflammation is a phenotype which is mainly the target for the biologic treatments. So what biomarkers would help us to do this? And here, as clearly said, the blood eosinophils, the FeNO or the fractional excretion of nitric oxide, sputum eosinophils, and the signs or the symptoms and signs of allergy-driven asthma would help us to see whether we have type 2 inflammation here or not. So, because the asthma biologics are quite expensive, the GINA guidelines still first recommends that before we start on biologic treatments, we will have to consider the non-biologic treatments, that is to first test whether the patient is adherent, and there are adherence tests. You check the prednisolone levels together with the cortisol levels to see whether the patient is adherent to his treatment or not. And then also you would try increasing the inhaled corticosteroid dose to a higher dose and assess in about another 3 months or so. And if there are any other comorbidities such as chronic rhinosinusitis, you can treat the patients with nasal steroids before we think about asthma biologics. So Also, as in our situation, mostly at the present stage, if we do not have biologics, what we should do is to consider again increasing the dose of inhaled corticosteroids, and then the LABA, LAMA, the leukotriene agonist, receptor agonists, and also whether we can use azithromycin in our patient. But make sure that before you put the patient on long-term azithromycin, you exclude non-tuberculous mycobacterial infection, and also you check the ECG to look for whether there is any QT prolongation before we consider starting on azithromycin. So if we do not have evidence of type 2 inflammation in our patients with severe asthma, we'll have to go back in the cycle of assessment, go to the basics, look for triggers. In overseas countries, what they do is the asthma nurse they visit their home and look for asthma triggers for the asthma, but that does not happen in Sri Lanka. So make sure that you ask thoroughly from your patient about all the triggers and whether you can address any of the comorbidities and then exposures such as tobacco and stuff, and then also the investigations to look for other contributing factors, and then thinking about a trial of long-acting muscarinic agonist or azithromycin in these patients as well. So this is a slide which is quite complicated, but this shows the asthma current endotypes or the phenotypes depending on the mediators they secrete to cause asthma. So we have two types, the type 2 high asthma and the type 2 low asthma, which is on the right side of the screen. So what is type 2 inflammation? It is mediated by eosinophils, mast cells, basophils, and the T helper cells, T2 helper cells, which secretes the interleukin 4, 5, 13, and also IgE producing B cells, which are causing the inflammation in allergic asthma or eosinophilic asthma. So in allergic asthma, the trigger is the allergens, as you can see, and it secretes all these interleukins and also with IgE and causing the airway inflammation and bronchoconstriction. In eosinophilic asthma, the triggers are usually pollutants, viruses, and bacteria, and you can see that they have more mucus production. They do not have allergic sensitization. They do not respond to anti-IgE treatment, and these patients are the patients for whom which the anti-IL-5 biologics have been helpful. And also, I would like to focus on this mediator, the TSLP, which is initially secreted by the epithelium in response to all allergens or any other trigger. And this is one of the current targets of the most recent biologic, which has been FDA approved in 2021 December. So on my right is the type 2 low asthma, which is called neutrophilic asthma previously, and in this subgroup we really do not know exactly what is the triggers and how it is causing all the problems, but then they have identified that interleukin 6, 17 and 18, interferon gamma and TNF alpha are found to be causing problems in uncontrolled asthma. Right, so according to the European Academy of Allergy and Clinical Immunology, eosinophilic asthma is defined as sputum eosinophil count of more than 1%, but GINA says it's 2%. So, because GINA guidelines are quite recent, the 2021 guidelines, so probably 2% is what most of the people are using. And also the blood eosinophil count more than 150 cells, and or the pheno levels more than 20 parts per billion is classified as eosinophilic asthma, while in allergic asthma, the total IgE levels is between 30 to 1,300, and also you would see in the history that there are symptoms of allergies. So this is also the same thing what I previously mentioned, showing the places where each biologic would be acting. I will not go through this slide in interest of time. So what are the similarities in T2 asthma and non-T2 asthma? So pathway involves the and the smooth muscle mass, increases the smooth muscle mass and fibrosis. There is mucus hypersecretion, thickening of the basement membrane, loss of epithelial integrity, and prolonged bronchoconstriction and airway remodeling. But then you would see that the eosinophilic phenotype and the allergic phenotype in T2 asthma, whereas it is mainly neutrophil driven in non-T2 asthma. So there are 6 biologics approved by the FDA so far for severe asthma. Omalizumab being the first, which is an anti-IgE treatment, and tezepelumab, which has been approved most recently. So what biologic to use? We have 6 of them, and what biologic to use? In Sri Lanka, it's very easy. We have no problem because we have none of the biologics. But then one fine day, we might have this problem as well, which biologic to use. So when you are thinking about what biologic, the dose of the patient's, whether the patient satisfies the eligibility criteria is one important factor what we should be looking at. And we should look at the predictors of good response. So each of these biologics have different predictors of good response. So whether our patient have those good response cohorts to think about which biologic for our patient. And then look at for type 2 comorbidities, which some of these biologics are good in treating as well. And the cost, obviously, and the dosing frequency, delivering route, and also the patient preference as well. So this slide would summarize some of the patient characteristics. The anti-IgE antibodies are mainly in the allergic phenotype, which is the childhood asthma, usually early onset, and then they have IgE sensitization, skin prick test is positive. They have found that if the pheno is higher, there is a slightly better response. If the eosinophil count is higher, there is a slightly better response in the anti-IgE antibody. Interleukin 4R antibody phenotype is for the severe type 2 asthma patients, childhood or adulthood onset. Irrespective of whether there are any allergic phenotype, we can use interleukin 4R receptor antibodies. And also there are criteria for the blood eosinophil levels, and the increased pheno shows that there is a better response. And it also can treat atopic dermatitis, chronic rhinosinusitis with nasal polyposis, according to the current research. Then the IL-5 antibodies are for the adulthood severe eosinophilic asthma, and you don't need to have any allergic sensitization, and irrespective of the total IgE levels, you can use it. The only requirement is that the eosinophil count should be above 150 to 300, which varies from center to center actually, depending on the availability and the funding for each biologic. Right, so the GINA guideline has put down these factors that would predict the good response to each biologic to help decide on what biologic and for whom. So I will not go through each of them because they are all what I just reiterated in the previous slide. So about the different phenotypes with allergy with only eosinophils, and there are some biologics which would work for either type of them, which is the most recent biologic. Okay, so for the allergic phenotype, omalizumab or Xolair is recommended. And it comes in pre-filled syringes given subcutaneously. Patient can administer on their own. Recommended for 6 and above years. And these patient selection criteria should fulfill. Patient should have severe asthma, all the other difficult to treat confounders, comorbidities have been addressed, but despite that they have at 2 or more exacerbations a year. FEV1 should be less than 80%. Serum IgE and body weight should be within the recommended guidelines. And also you should demonstrate skin prick test positivity or the specific IgE increase for aeroallergens for patients to receive Xolair. Right? So The main adverse effect of this drug is anaphylaxis, which is quite rare, but then it can happen not mainly within the first 2 hours, but also late onset allergy can occur as well. So most of these patients are given an EpiPen to keep with them at home. So ideally, before we give the Xolair dose, we check whether the EpiPen expiry date is within the correct period, because otherwise we do not administer this. And also if the patient has a chest infection, we would delay the dose maybe by a week and treat with some antibiotics. So this is all what I told previously. The mechanism of omalizumab binds the IgE and prevent allergic inflammation. And the extra study, which is a prospective multicenter randomized parallel group double-blinded placebo-controlled trial, which showed that this Xolair is able to decrease the exacerbation rate, and this was greatest in the 3 high biomarker subgroups. What are they? The high FeNO, high eosinophil count, high IgE, and also those 3 phenotypes. Okay, I think I have. Right. Okay. So then when we go to the experience registry, which is the real-world extensiveness of omalizumab in allergic asthma, they have showed that in about over 260 patients, baseline oral corticosteroid dose has been reduced by 57%. But still, even though this observational study shows that there is no clear evidence or randomized control trials to say that it reduces the need for oral corticosteroids. And then when you're talking about anti-IL-5, these are all what I told previously. There are good response parameters which we use to decide on which biologic we are using. Mepolizumab was the first IL-5 which was recommended, and it is also given subcutaneously, and the side effects are more or less the same except for the helminthic infection risk, which would be quite important in a Sri Lankan context. So the DREAM trial has showed that the rate of clinically significant exacerbations was reduced by 39 to 48% with mepolizumab, but there was only very small effect in improvement in FEV1 or quality of life in these patients. So the trial done to see whether there is an glucocorticoid, oral glucocorticoid sparing effect in mepolizumab showed that there is a significant glucocorticoid sparing effect together with the significant reduction in exacerbations using mepolizumab. Then reslizumab is the one and only biologic given intravenously, and it is also like mepolizumab, interleukin-5 receptor antagonist, and recommended for patients more than 18 years, and has more or less the same side effect profile as well. The 2 duplicate multicenter studies, phase 3 trials, showed that the treatment with reslizumab reduces the frequency of exacerbation significantly using reslizumab. And this also shows that there is a modest improvement in FEV1, which lasts for about 16 to 52 weeks as well. Right, so for patients with eosinophilic phenotype, also again, benralizumab is also recommended, which is recommended for more than 12 years, given subcutaneously. Same adverse effect profile, and the peripheral blood eosinophil count should be just more than 150 microliters. So more or less they are the same, and the efficacy is same. There are no head-to-head studies to tell which is better from which. So it is your clinical decision and the patient profile which we should guide you with, and also probably an MDT to decide, rather than one head thinking about multiple heads would give a better answer for these questions. Right, and then the dupilumab is the interleukin 4R receptor and antibody, which blocks IL-4, IL-13 pathway together, and therefore it has shown better improvement in patients because it blocks both IL-4, IL-13 as well. This is the most recent FDA-approved biologic, the tezepelumab, which is given subcutaneously, and this is recommended, and this has shown that it improves symptoms, whether you have severe asthma with any allergic phenotype or eosinophil phenotype as well. So this forest plot shows that you can see whether the eosinophil count, whatever the eosinophil count, it's beneficial. Whatever the blood eosinophil count, it is beneficial. Pheno at baseline, it's whatever is beneficial. But also you can see that the higher the eosinophil count or the pheno, the response is much better than in the lower group. Right, so when we are talking about biologic therapies as, and the biologic therapy as, what is the efficacy, you can see that all biologic therapies improve quality of life and reduce severe exacerbations. Only the dupilumab shows clear evidence of lung function improvement together with tezepelumab, but it is quite new, so we need to look for further research in that. But none of the others shows a sustained improvement or a significant improvement in the lung functions. Glucocorticoid sparing effect is seen in mepolizumab, benralizumab, and dupilumab, but not in rituximab or tezepelumab. And omalizumab also needs further studies. So to finish with, I will start with one of my patients whom I treated while I was in my overseas training. This Miss H, who was a 14-year-old girl who was on high-dose inhaled corticosteroid, LABA, and who needed rescue bronchodilators at least 4 times a day. And she was on regular theophylline as well and nodokromil before exercise. And she had hay fever, eczema in the past. She had multiple visits to the A&E, lung functions, low lung functions less than about 65% FEV1. There was good bronchodilators response. Pheno was slightly elevated. Sputum only 0.5 E count. CT, there was no bronchiectasis or any other abnormality. IgE was elevated. Rest of the immunoglobulins normal. The RAS test was positive for house dust mite, so she had allergens. And the prednisone and cortisone levels had evidence of good compliance. And so parasitic screening was normal. So after bronchoscopy and various tests, looking at cardiac MRI, sinus CTs, she was commenced on omalizumab, and depending on IgE level initially and the body weight. And each visit, she was quite compliant, and then with the test, what I told you, we are accessing for acute infection, lung functions, and monitoring for 2 hours after the dose. She was quite good with her treatment, and after 9 years of omalizumab, the FEV1 was 2.05. There was no exacerbations over the last year I saw her, and the saturation was about 96% on room air. Peak expiratory flow rate was around 360, and she was off prednisolone. To tell you all, she was, to begin with, on the referral letter, she was on 40 milligrams of prednisolone, and then at last she was off prednisolone for quite a few years and was doing very well. So the biologics experience in Sri Lanka, I know that Dr. Nandika was able to give the first dose of omalizumab, but then availability and affordability has been a problem. What about the parasitic screen in Sri Lanka? Should we treat with antihelminthic treatment? Are some of the questions what the asthma assembly would face with to give some answers most probably. So in summary, biologic therapies target type 2 inflammatory pathways that are central to exacerbation pathogenesis in asthma, and elevated blood eosinophils together with FeNO are associated with greater clinical efficacy with all of these biologics. All biologic therapies have been shown to reduce exacerbation frequently in controlled trials. Mepolizumab, benralizumab, and dupilumab are the only biologics to achieve significant reduction in daily oral corticosteroid use or the dose. Specific allergic and eosinophilic comorbidities, as well as patient preference and practicalities of drug delivery will influence biologic choice in a country as ours as well. Thank you.
Thank you, Dr. Dilesha, for that talk, an area where we haven't done much, I suppose, as respiratory physicians, because the first biologics was available in the market in 2003 or even 2002. So after 20 years, still we are not able to get a biologics. So it's very sad. Obviously, we come across a lot of refractory asthma patients who are on a lot of medications, and still they are getting exacerbation and so on, like you have explained. So my question here is, we don't have any questions. If you want any questions to be asked, yes, from the audience. Right. So basically, now in refractory asthma, we were talking about evaluating after Dr. Amita Fernandez talk on comorbidities. So how important it is in this group of patients to evaluate and treat the psychological, or most of these people are depressed. They are, I'm sure you saw your patient who was whom you have seen in England with a body weight of 118 kilograms. So in that context, how important it is to evaluate these comorbidities, especially this psychological and psychological factors, so psychosocial factors.
So it's very key to think about depression, anxiety, and all the psychosocial problems, because in fact in our difficult to control asthma workup, it should be a key component, and you should have in your, if we are to ever have a multidisciplinary team for difficult to control asthma, we should have a psychologist or a psychiatrist to address these symptoms, because all these patients are depressed and they are helpless, quite anxious about their breathlessness. So these patients need to be assessed. In fact, the MDT, which I had experienced in my overseas training, had a speech therapist, an occupational therapist, physiotherapist, and the psychologist as team members, and they definitely at the first visit of the patient, they would see the patient, assess and address any problems they have before they start on any biologic treatment.
Thank you. Just to add up, why we have, my personal view, why we have taken so long not to have any of these medications is, now if you know most of the things, like I'm sure Dr. Yamuna will tell, we have got e-bus, radial e-bus and everything so fast, but we haven't got a biologic which has been there for the last 20 years. What I feel is, our patient group of patients, our expectations of their quality of life is very low. So their expectations and their day-to-day activities, what they are supposed to do or what they have to do, they have brought down quite a low level. In fact, probably with the social setup itself, within the family itself, oh, she's a patient, she can't do that, she can't go to work, that kind of social, I can't say it as a stigma, but it's a social setup which has caused, probably, they don't know how much they can do. In fact, we don't know how much they can do. That's why we are lagging behind. Right. Just to wrap up, thank you very much, Dilusha, for that wonderful talk. Let me ask my co-chair, Dr. Tushara, to award a token of appreciation for your work. Thank you. So for the final talk of the day, would be the presentation. Dr. Tushara will introduce our presenter.
So we'll move on to next, the last talk of the day. So it's my great pleasure to introduce next speaker, Dr. Yamuna Rajapaksha. She is the consultant respiratory physician and senior lecturer in anatomy, Faculty of Medicine, Colombo. So she will talk on what's new in asthma management. Over to you, Yamuna.
And thank you, Tushara. Good afternoon, everybody. So I will be wrapping up this entire, I think, very extremely important session that you have been having since morning. And I would like to start by thanking what Dr. Afla said, because yes, why are we so late in adopting these very important new things that are actually not new? Most of the things that I'm going to talk about are not new to the world, but they are indeed new to Sri Lanka. And because you have had a lot of lectures which have spoken about the new things that we need to talk about, my talk is going to be more about how we are going to change our thinking. So basically the main new thing we have to do is change our thinking pattern to adopt a new way of thinking rather than going with what we have been practicing for the past 25, 30 years. So it's going to be more of a summary, but I urge you to sort of try and think in a new manner as to how we are supposed to treat our asthma patients and how we are going to change the country's, again, what I mean, thinking pattern or scenario. I know we can't do much with the financial situations, but we can indeed do a lot with our perception and the perception we give to our patients regarding asthma. So, as the first slide shows, asthma control is not only a problem in Sri Lanka, it's a problem across the world. You can see in Canada, 90% of patients have asthma that is not well controlled. And this is a country which has a lot of a good financial structure, it has a lot of biologics, it has everything, but still their patients are not controlled. In the United States, 85.7%. Latin America, of course, I think is a bit more towards the third world. Even there, it's 93%, not much different from Canada. And in the Asia Pacific region, very interestingly, it's 46.9%. Now, why do you think that is there? Our problem has to be the way we measure or think about control. Again, as Afla said, how do we look at our patients? Why do we think our patients are not controlled or controlled? These are from studies which are mainly questionnaire based and patient perception. So our patients generally think being able to walk from here to there on a flat surface is fine. I'm good. But they don't aim higher. Okay, so that is what I mean by change in our perceptions. So asthma research is something which is very, very widespread. Produces up to about 9,000 publications a year, and it's a very rapidly developing study area which we need to address very quickly. We need way more research than we are already doing regarding asthma, its treatment, and basically people's or patients' perceptions regarding the disease. So most of the novel developments of the last year have focused on areas of precision medicine, like Dr. Dilisha mentioned, endotypes and phenotypes, which we have been talking throughout, biomarkers, which I will give a little overview on, and novel treatments such as biologicals and certain real-life studies. So the past 2 years, in spite of the COVID pandemic, there has been a significant advance in asthma management. Maybe it's because of the COVID pandemic that people were made more aware of certain things in terms of asthma as well. So they have focused more on asthma pathogenesis with resident cell compartment, epigenetics, and immune system effects, again, which were explained quite comprehensively by Dr. Dilesh in the previous talk. But we have to focus on several randomized clinical trials with good quality real-world evidence, like the following. So there was this GINA Expert Panel Report 3. ERS ATS guidelines on severe asthma and the EAACI guidelines for the use of biologicals in severe asthma. They have also put out a position paper on COVID and asthma as well. Then there have been these 6 priority topics identified for systematic review in the NAEPP, which is the National Asthma Education and Prevention Program, which is based in the United States. So out of the 6, from this, you can see the 6 up here now. FeNO in diagnosis is to be more reviewed. It has become a very important diagnostic and follow-up method in terms of medication selection and also monitoring of treatment response in asthma. Then the remediation of indoor allergens. We have been speaking about this for the past, I know that Dr. Amita Fernando has been focusing on this for as long as I have known, sir. And it's sad that we are still going to be talking about this instead of presenting actual research that we have been doing. Thirdly, adjustable medication dosing in recurrent wheezing and asthma. Then long-acting antimuscarinic agents in management as add-ons to inhaled corticosteroids. Immunotherapy and management of asthma. And finally, bronchial thermoplasty in adult severe asthma, which really needs to be studied more. There have only been 3, I think, good trials conducted since the advent of bronchial thermoplasty, mainly because it's a very expensive and tedious procedure. So when I talk about what is new, I said this is more of a summary of what was presented entirely today. I will talk about what is new in diagnostics and what is new in management. Now please understand that this is not going to be very high flow in diagnostics, you all know this. And I want to stress that all these diagnostic methodologies are things that you can do and things that you need to be aware of, which are available in the country. And I urge you to start using them instead of just following the same old diagnostic pathway. So in terms of diagnosis, asthma needs to be diagnosed and treatment monitored. Then the specific comorbidities need to be diagnosed as well as etiological factors, which we need our immunologists' help with. Then in terms of management of exacerbations, long-term management, and management of our causative factors or etiological factors, which has been addressed, but I will do a brief summary of all that. So what is new in the diagnosis? So again, the phenotype-driven versus endotype-driven diagnosis is a theme which keeps on recurring. So do we categorize our patients by the underlying disease process or by specific clinical characteristics? Again, there's an analogy with anemia, like Dr. Chandra mentioned. So anemia is a symptom, and giving a blood transfusion will sort of cure the anemia very temporarily, but we have to look for our underlying process first. So similarly in asthma, an endotype, it gives you a distinct group with a well-defined cellular or molecular biomarker and a discrete underlying pathology, whereas a phenotype talks about observable symptoms or disease characteristics. So phenotypes are more like this anemia situation where we need to actually treat it to get our patient, back on board and not, prevent dying. But in the end, we have to go and address our endotypes as well. So for endotypes, it requires a knowledge of the underlying cellular molecular pathology, and Dr. Dilesha showed very well in those diagrams some of the pathways that are endotypes. And this would target, all the drugs she mentioned are targeting the underlying mechanism directly. Whereas in phenotypes, which is what we normally find in our patients and what we are treating, we have to assess clinical, functional, radiological and biological parameters to arrive at the phenotype, and it will help us select the drugs that improve the observed clinical presentation. So once your patient is stabilized, then you have to quickly move on and find out what your endotype is, if it's possible. So I understand, you have to understand that some of these tests are not really available yet. The problem with both these types are, the challenge was that we can't focus on one alone. We have to have a universal diagnostic pathway. So in the future, they are thinking of multiple pathways linked with biomarkers that can help us unify the two phenotypes and endotypes. So with this search came this treatable trait model, I have given the reference below. So these treatable traits are certain observable components that can be modified to improve well-being. And it is a very much clinically useful way to classify asthma rather than really focusing on one type or the other. So these are based on pulmonary, extrapulmonary, and behavioral or psychosocial characteristics. So going to the pulmonary, the symptom-based traits would be wheeze, cough, breathlessness, which is how we diagnose clinically our patients. But you have to also look at modifiable exposures, like Dr. Amita Fernando mentioned, the allergens, infections, exercise, and occupational exposures. Then you have to look at functional traits, whether there is variable airflow limitation in everyone you see, how much bronchial hyperresponsiveness there is, and if there's a fixed airflow obstruction in any one of them. Radiologically, we can look for air trapping. And biologically, check for elevated FeNO, blood or airway eosinophilia, and elevated total or specific IgE because we have specific targeted treatment. Then pathologically, airway remodeling. Extrapulmonary features, which have been mentioned before, are obesity, obstructive sleep apnea, rhinosinusitis, eczema, GORD, dysfunctional breathing patterns, and inducible laryngeal obstruction. Again, very importantly, some traits are behavioral or psychosocial, like anxiety, depression, smoking, and poor medication adherence. So these are clinical features that we should focus on in terms of diagnosis and following up our patients. So what are the available diagnostics, which have been mentioned before as well? So our mainstay of diagnosis is spirometry with bronchodilator reversibility. I don't need to tell you about that. But we should focus more, I think, on the flow volume loops that you see here, because that gives us a lot of information that we really tend to overlook in many of our spirometry results or reports. Then we have other very important tests like assessing our variable obstructions, so peak expiratory flow, which has been talked about extensively, and also the bronchoprovocation tests like the methacholine inhalation monitoring, and then indirect challenge tests, which are now available here. So the problem with these tests that I mentioned here is we are more focused on talking about interpreting large airway pathophysiology. Whenever we do a spirometry, we are really focusing on the larger airways. Whenever for example, even though we do a bronchial thermoplasty, we are still focusing on something like a larger airway. So how do we go and look at our small airway? So that is becoming, or it has become a focus of research recently. The small airways, which are defined as airways without cartilage, so mainly smooth muscle is the structural component, and are less than 2 millimeters in diameter. Why have we been focusing on large airways? Because minimally invasive tests and they are easy to access. We have spirometry everywhere. However, now we know that small airways in patients with asthma are a significant contributor to airflow limitation. They are not audibly wheezing. We will not hear any rhonchi when they present to us, but they do have small airway pathology, and this is what we need to catch. So there have been tests which are focusing more on this. So pathology can occur in small airways of patients even before changes are detected in spirometry and even before onset of the typical asthma symptoms. Right. So these tests are going to help us detect asthma earlier and detect asthma in patients who we cannot administer spirometry to. So some tests of small airways would be the functional tests like impulse oscillometry and multiple breath washout testing. Both of these are available in the private sector. Impulse oscillometry is available in the state sector as well in Sri Lanka. And also there are the tests that detect underlying pathology like breath composition analysis and particles in exhaled air. So this is the measurement of airway resistance. You see a body plethysmography test being done and an impulse oscillometry interrupter technique done in a small child. And it's a very good test to check for small airways disease in children who do not understand how to do a proper spirometry. So impulse oscillometry is going to measure airway resistance, and this will be more targeted towards the smaller airways. Multiple breath washout, I don't have a picture of. It's done in the private sector here. Measures something called a lung clearance index, and they administer a tracer gas and you see how many cycles of breathing is taken for the tracer gas to be completely eliminated from the lungs. So you do it to check for lung volumes as well as for small airways disease. Then exercise challenge testing, which is a bit different from the CPET, but it's similar. That's to check for exercise-induced bronchoconstriction. Again, it's available in Sri Lanka, where you do a pre-exercise spirometry, and then you exercise the patient using a treadmill or a stationary bicycle for 6 to 8 minutes. And then you continue monitoring spirometry measurements for about 15 to 30 minutes post-exercise. Now, this is done for athletes mostly who can tolerate exercises like this. But of course, sometimes you need to take the athlete to their own athlete environment if there's an availability of outdoor spirometry equipment, and do the test, because then only you can properly gauge whether this person is having exercise-induced asthma, which pertains to their activity levels. If a patient cannot do this type of exercise, other cardiac causes, etc., you can do these other challenges mentioned, like the methacholine challenge, something called eukapnic voluntary hyperventilation, I think Dr. Niranjan mentioned it, and mannitol challenge, hypertonic saline challenges. We do these things. However, it was stopped, like Dr. Amita mentioned, because it needs to be done in a setup where we can address emergencies. So an in-hospital setup is needed for some of these tests. So like I said, eukapnic hyperventilation or eukapnic voluntary hyperpnea delivers delivers dry air with 4.9% or 5% carbon dioxide. The thinking behind this is dry air needs our airways to humidify it, right, before it goes into the alveoli. So in the process of humidification of dry air, we lose a lot of water from our system, and that in turn causes bronchial constriction. So based on that thinking, this test, hyperventilation, can be done. Now in hyperventilation, you know that carbon dioxide can be washed out, therefore we add the 4.9% carbon dioxide to the breath mixture that we are breathing. So here it's done for 6 minutes, and FEV1 is measured in stages. So a positive test will be more than 10% drop in FEV1. So this is again a way of checking for exercise-induced bronchospasm in the absence of doing an actual exercise. So again, going to what Dr. Elisha was talking about, these are not exactly very new, but new to Sri Lanka, new to us. Eosinophils being used as biomarkers. We have done blood eosinophil counts for as long as I can remember. But we can also do breath eosinophil levels as well, sputum eosinophil levels, and this is known to be associated with steroid responsiveness. It's a biomarker for biological therapies targeting allergic or eosinophilic pathways. Then there is known efficacy and safety of all these biologics that were mentioned in the previous talk. Another exhale biomarker which is available now is pheno or fractional exhale nitric oxide is done, and studies are available in Sri Lanka which pheno has been used in children, and it's very good for type 2 driven airway inflammation testing, especially it's an upper airways test. Then there are also tests for exhaled breath condensate or volatile organic compound testing. Other methods you can use to detect pheno, and you can use to detect various other things from the lower respiratory tract or the smaller airways, like I mentioned, was important. Further biomarkers that can be tested, IgE. IgE, now you know extensively about how IgE acts. So the fact that total serum Ig and allergen specific Ig has been strongly associated with asthma, IgE can be used as a very good biomarker. And there are newer digital asthma biomarker sensors especially this thing called e-nose or an electronic nose, which has the potential to assess asthma control and tailor treatment. So this is mainly used to identify atopic individuals by breathing out. The e-nose has been used in various other lung pathologies, especially like lung cancer, to identify early lung cancer. But it can identify individuals with persistent asthma who have been prescribed corticosteroid, and supports the diagnostic ability of this method to identify individuals who would need corticosteroid therapy also. So then what is new in the treatment of asthma? I told you what should be new is the way we think about it. So how we move forward is optimizing our known treatments, that is key, and implementing novel approaches also as far as we can. So the concept of personalized asthma is again very important. We have been talking about it the whole day. One size fits all does not apply anymore. The fundamental change in GINA 2019 has been addressed. I will just summarize that. And the fact of comorbid treatable traits in difficult asthma needs to be addressed. Extrapulmonary comorbidities are known to improve asthma outcomes. For example, the treatment of rhinitis, chronic rhinosinusitis, GORD, and obesity. Then the targeted assessment of difficult to treat asthma patients, including questionnaires, specialist assessment, and tailored referrals. We should be continuously assessing our patients. So that is again meant to be new thinking, although we should have been doing this for a while now. Then the addition of biologics and other novel. If you notice, that is a very last thing. We can do way more things with the change of our thinking patterns to the new way rather than adding a lot of new things. Then maybe the new things will be available. So you have seen this cycle about the review, assess, and adjust. I'm not going to go into that. Then the fundamental change in asthma management in GINA 2019 was that GINA no longer recommends the short-acting beta agonist. Please remember that. You know how every patient that you have encountered is scared of an inhaler. You have to convince them a lot to be able to tell them to take an inhaler. What we don't realize is that we are also scared of inhalers. We are scared to prescribe inhalers, and we do not want to give patients a combination ICS LABA, for instance. We think, no, we'll just give the patient a SABA inhaler and, hope for the best or something. We can't think like that anymore, especially when there's a guideline-based backing for y'all. Go for it and prescribe your ICS LABA combinations, because it is proven that in starting a short-acting beta agonist only inhaler does more harm than good. It increases the risk of severe exacerbations, and adding any inhaled corticosteroid significantly reduces the risk. So this was a game changer which happened in 2019, and it's again not very new, but we need to change our thinking. So GINA now recommends that all adults and adolescents with asthma should receive ICS containing controller treatment, and this can be delivered daily by an as-needed low-dose ICS formoterol combination. This is a similar population-level risk reduction strategy, which is similar to, say, statin therapy and antihypertensive therapy, which people just give without a second thought. So this was also spoken about. What are the background risks of mild asthma? So I'm not going to go into detail. Exacerbation risks are unpredictable, yes. So viruses, pollens, pollution, and poor adherence are always going to come to the fore, and you have to keep on searching for these with your patient, not to just prescribe a continuation inhaler. So it's very difficult to change people's mindset about the inhaled SABA, which has been the first-line treatment of asthma for 50 years. It is a good drug, yes, but because now we have these combinations, we have to use them. Patients have also, when you start with the SABA, they also try to think of it as their primary asthma treatment. So the training of our patients also has to change. Go to this one, which you have seen again, showing the stepwise treatment, beginning with the ICS formoterol, Of course, for people who have already been using their SABAs, they have given a bit of a leeway, an alternative pathway to be using this, especially in countries. Now, even here, I don't know whether it's going to be unavailable very soon, the ICS formoterol combinations. So we do have an option of continuing with the ICS with the SABA, but we do not have any place of using the short-acting beta agonist alone. We have to use it with the inhaled corticosteroid. Then the maintenance and reliever or MART therapy, which is again spoken about, reduces the risk of severe exacerbations, both in step 3, 4, and 5. There is no evidence about initiating maintenance and reliever therapy in patients receiving add-on treatment such as LAMA or biologic therapy. But if the patient is already taking MART, switching them to conventional ICS LABA plus an as-needed SABA might increase risk of exacerbations. Then step 5 regarding the add-ons has also been spoken about. They have studied lung function from adding LAMA to medium or high dose ICS LABA, and it modestly improves lung function, but not really the symptoms. Then add-on azithromycin, again, add-on azithromycin 3 days a week has been confirmed as an option for consideration. So add-on biologic therapy, which we spoke about quite a lot, so I'm not going to go into detail for this. What is not recommended, however, is the sustained release theophylline, which has only weak efficacy in asthma. And also chromones, agnidochromyl sodium and sodium chromoglycate, have a favorable safety profile but very low efficacy. People who have exercise-induced asthma basically have poorly controlled asthma. It is not a different type of asthma, it is a phenotype, and they can be treated well if they are controlled well with regular inhalers. It's not necessary to give them chromone therapy. Then the novel treatments, which is again something which has been mentioned, the 5 biologicals approved, which Dr. Dilisha mentioned very much, and they're known to have steroid-sparing effects and to reduce asthma exacerbations. Another one which is coming up are these arginase inhibitors, which is known to be seen to be promising, which leads to an increase in nitric oxide levels and promotes bronchodilation by inhibiting airway inflammation. So the drugs for arginase inhibition are still being developed. Then allergen-specific immunotherapy, which is actually the only causal treatment in allergic asthma. The sublingual allergen immunotherapy tablets for pollen allergy can reduce the prevalence of asthma, decrease medication usage, and slow down progression. So I will leave you with this picture, which is management of asthma patients during COVID pandemic. I know a lot of data has come in because of the COVID pandemic, and asthma research has sort of jumped into a next level because of this. What we need to know is that asthma is not a risk factor for the development of severe forms of COVID-19, but it can be a severe disease in already damaged lungs, especially in chronic asthmatics, in ACOS and COPD patients particularly. Patients should receive their COVID vaccine without delay. Patients are really worried sometimes to take the COVID vaccine, thinking their asthma is going to get worse because of it. We need to change that, get them to take it. And of course, this European Academy of Allergy and Clinical Immunology position paper, among other things, mentions personal protection for asthma patients, social distancing, I mean, it's good for everyone, and then control of symptoms, as well as usage of ICS and other asthma controllers should be continued even when they get COVID, especially when they are diagnosed with COVID. Right, so I hope you understood what I was trying to tell you. I do not want to talk a lot about the genetic, epigenetic factors of asthma, because those are not going to come definitely to our neck of the woods very soon. But you have to change your thinking and your patient's thinking towards the newer things you can do with existing treatment. We have to, like our chair said before, do not settle for an ordinary level of activity with your patient. Try and aim for more and see the optimum your patient can achieve in levels of control. Thank you.
Thank you very much, Yamuna, for that excellent lecture. Do you have any questions from audience? Yeah, in the absence of any questions, we'll conclude the session. Then again, I would like to thank Dr. Yamuna Rajapaksha for that excellent lecture. And Afla will present you a token of appreciation on behalf of the college.
Thank you, Dr. Afla Sadikin and Dr. Tushar Galabada, for successfully chairing today's academic session. Now, as all good things come to an end, we have now come to the conclusion of today's event. And I would like to cordially invite Dr. Tushar Galabada to deliver the vote of thanks in concluding today's activities.
Good afternoon to all of you. Ladies and gentlemen, so we have come to the conclusion of this year's World Asthma Day academic program. I'm sure it was an excellent educational experience for all of you. It must have revised and updated your knowledge on asthma. So on behalf of Airway Assembly of College of Pulmonologists, it's my great pleasure to deliver the vote of thanks. First of all, I would like to extend my heartfelt gratitude to all the speakers who came here physically as well as who joined us virtually. The lectures were really outstanding, and also I would thank all of them to be on time. We are on time. Then I would like to express my sincere thanks to all the students who sent their beautiful drawings to our art competition, which made our attempt to educate our school children a success. And a special thanks should be given to Mr. MSSB Ratnayaka, an art instructor attached to Education Department, Colombo Division, and Dr. Bodhika Samarasekara, the consultant respiratory physician, who helped us in judging the art competition. Then I would like to thank the president of Sri Lanka College of Pulmonologists, Dr. Ravini Gunatilaka, joint secretaries and the council for the continuous support and the guidance given throughout. I'm very much grateful to all the members of Airway Assembly of the college. Without your support, it won't be possible to conduct an academic program of this nature. I'm grateful to my co-chair, Dr. Afla Sadikin, consultant respiratory physician, who came to chair the session despite his busy schedule. And I would like to extend my sincere gratitude to all the attendees who joined with us today, physically as well as virtually, despite the difficult situation we are facing in our country. A special thanks should be given to our sponsors, CIPLA. Thank you very much for your continuous support throughout. Last but not least, I would like to thank the Nalina and the team who made this event a hybrid event. Buaneka, a medical student who helped us with all these creative works. Sonali, our office secretary, and Lakindu, today's computer. Thank you very much for your attention.
Thank you, sir. And that brings this year's World Asthma Day academic program to a close. We thank everyone who joined with us today, and we hope to see all of you soon in the upcoming events. And until then, stay safe and have a pleasant day.